Committee will come to order. And before we get started today, I want to thank the committee members for all the hard work they did on the Blue Water Navy. This has been a passion of this committee and mine and Mr. Walls for literally the whole time I've been in the Congress. And this committee delivered by voice vote. And then yesterday, I think proudly we can say we made our case. We're 382-0. Finally, this wrong is being righted, and I want to personally thank every member of this committee for the work you did, the dedication on both sides of the aisle. So from me to you, thank you. Well done. Thank you all for being here today to discuss VA's Electronic Health Record Modernization Program. Much has been said and written about the program since June 1st of last year when former Secretary Shulkin announced his decision to commence negotiations with Cerner. Opinions have been formed and conclusions have been drawn. The reality is, even with the contract awarded and work underway, we are at the beginning of the beginning. We all know the broad strokes that led to the HR modernization. The VA IT budget is consumed by operations and maintenance costs. VA's health information system, VISTA, is functional but increasingly complicated while the EHR industry continues to evolve. Also, it is well past time for VA and DoD to achieve seamless interoperability because service members and veterans deserve a lifetime medical record. I've heard Mr. Walls say that for 10 years. VA leaders were guarded in how much they would discuss during the negotiation. To some extent, that's understandable, but it's time to delve into the details. $15.8 billion over 10 years, including $10 billion to Cerner, is a staggering number for an enormous government agency. That's $15,800 million when you put it in terms like that. I don't know about where you're from, but where I'm from, that's a lot of money. However, EHR software is only a relatively small part of the overall price tag. What exactly does all that money buy? Everyone here today knows the adage, if you've seen one VA hospital, you've seen one VA hospital. Part of the reason for that is for 35 years, VHA has had a culture of creating software to fit any process and a technology platform, VISTA, that facilitated it. There's much to be said for local authority in healthcare. I agree with that, but it seems to have gotten out of control and made the IT landscape ungovernable. The EHR modernization is not just a technology project. It will have a major impact on the way VHA operates. That means clinical and administrative workflows. It also reshapes the culture as VISTA has. However, if imposed on clinicians from the top down, the culture will reject it, and no amount of technological savvy will be able to save it. If we were creating a veterans healthcare system from scratch, implementing an EHR would be relatively easy. But that's not the reality. Transitioning away from VISTA is the most difficult aspect of the EHR modernization. VHA and VISTA have built up around each other for decades. Amazingly, even after all these years, the department does not seem to have a complete technical understanding of where VISTA begins and ends. It's not an oversimplification to say the EHR modernization team may still be figuring out what VISTA is up until the day they turn it off, if ever. The scale is daunting and the ambition is impressive. That's evident. I'm interested in the benefit at the end of the 10 years to a veteran and to the clinician. The lifetime health record has to be worth the potential disruption. The ease of use, the new analytics in the EHR have to be worth the learning curve. Those things are difficult to quantify, but if the equation does not balance, it will be abundantly clear as soon as the system is turned on in the first medical center. I believe VA has been realistic about the level of resources needed to manage the EHR modernization, and by every indication, the EHRM Program Executive Office is building a good structure to do that, but they will need a great deal of help. The program cannot be seen as just the responsibility of an office in Washington. VA senior leaders, VHAs throughout the country, and Office of Information and Technology, and every other corner of the department must be invested in its success. I especially appreciate all our witnesses agreeing to testify today. It is a large and impressive group on two panels, including some new faces for the committee. You've all demonstrated an interest in the EHR modernization success. My colleagues on the committee and I are committed to doing our part. That's why Ranking Member Walls and I have decided to create a new subcommittee on technology modernization to focus on oversight of the EHR modernization program as well as VA's other enterprise modernization projects and programs. The subcommittee will allow a small group, 3 to 5 people, of committee members to focus intensively on these issues and strengthen the work the staff has already been doing. The EHR modernization is a big bet on the future of VA, and we simply must make sure it succeeds. More details will be available as we constitute the subcommittee in the coming weeks. I've been through this process from paper to electronic. It is not easy. Going from electronic to electronic, I feel, is going to be even harder. I think the technology is going to be difficult, and we have to be patient. And we certainly have to start at the supply person who's working in the ER supplying things, from the nurses who are spending way too much time looking at a computer screen and not at patients, and to doctors who are doing exactly the same thing. If it doesn't free up our clinicians and our supply people and our other people for more time with our patients, then we've failed. So with that, I yield to Ranking Member Walls for his opening statement.
Well, thank you, Chairman. And again, I want to thank each and every one of you and your leadership on Blue Water Navy. You set out to do it, and as everything you've done, you've accomplished it, and I am grateful for that, and so are many of our warriors. The Chairman is right. 12 years ago in the first committee here, I remember saying that I hope I would be here long enough to see the implementation and a movement towards electronic health record, a joint electronic health record with DOD, and having an understanding that that is far more than a database. That is a diagnostic tool and everything else that goes with it. No one knows better than the Chairman on the complexities of this. To get this done right is going to take transparency and oversight. The creation of this subcommittee is a great first step. If I've learned nothing in those 12 years of being here, that especially when it comes to everything but the VA in particular, and whether it's Denver, Phoenix, or projects that have worked wonderfully and moving forward like Omaha, leadership will make or break this project. So will the oversight, which is why I enthusiastically support the creation of this new subcommittee overseeing a $16 billion decades-long process. There are going to need to be eyes on this all the way, and every one of us up here, we own this now. We own this. We can complain about Denver. We can try and get fixes. We get to start fresh. And I would own that, and I said I think we should take the responsibility that everything that goes wrong with this now or goes right should be the responsibility of this committee to take a look at it, and that's what the Chairman's putting in place. But to do that, we need to have the capacity, and that means the GAO and the IG must be given the access they need to independently oversee progress on implementation. GAO should be in attendance at every single governing board meeting. GAO must have direct and frequent access to VA, Cerner, and program management support contractors. I want the GAO to review quarterly progress reports. IG must have access to these documents and information it needs to regularly monitor implementation and be ready to follow up, audit, and investigate when significant issues arise. We're going to have to partner in this. So today at 9:01, I received the documentation that talks about the establishment of the Office of Electronic Health Records Modernization. No communication with us before this, nothing there. You sent this to us electronically, and on the second page, Mr. O'Rourke, it has your signature with attachment. No attachment was there. It's electronic health records management. You can't make this stuff up. We get an improper electronic transfer of information setting up the office. This is why there needs to be oversight. And I'm going to have questions as we go through. Where is Mr. Sandoval today? Where is the Chief Information Officer? Where is the person that's going to ultimately or should be ultimately responsible for this? It's important our watchdogs are empowered to effectively hold VA accountable to veterans and taxpayers. This committee's done that. We've held people accountable. We've protected whistleblowers, and we've uncovered abuses that hurt veterans. That only happened because the IG and the GOA were there. It's not up to the VA Secretary or Acting Secretary to decide when an IG investigation occurs. You do know, Mr. O'Rourke, you have no authority to remove an IG. None. Statute does. You do not have that authority. When something occurs, IG needs to access documents and records. It's not up to you to determine GAO's level of access. I raise this issue because VA OIG has yet to be granted access to the Office of Whistleblower Accountability and Protection database. Mr. O'Rourke said that organization is accountable to him and loosely tethered to him. That is not the case. They're to you for your budget, but not for the authority. What is true is you are not loosely tethered to this committee. You are constitutionally tied to this committee and the oversight that will be provided from this committee. I don't want to hear reports a year from now, IG are being denied access to documents relating to electronic health record modernization. VA stonewalling must not be tolerated. It can't be tolerated by any administration. It happened where we had it last time, and we needed to subpoena documents to get that from the administration to find out what was happening in Phoenix. Now we have the IG clearly asking for these things and being denied those things. So today I'm going to want assurances that the IG will be granted access to the Whistleblower Protection Program. The IG and the GOA will be granted ready access to oversee electronic health modernization. Capable and good leaders welcome transparency and independent oversight. Capable and good leaders do not threaten the independence of the IG. Capable and good leaders welcome GAO's involvement in every aspect of this project because the outcome is a product that delivers and improves care for our veterans. That's what all of us want. We cannot have a bureaucracy clogging that up. We cannot have a bureaucracy that will not let independent eyes see that. We cannot let a bureaucracy not be accountable to the elected officials that sit here who are responsible for those veterans. So I find it deeply concerning executive in charge of the operation of information technology, Mr. Sandoval, is not testifying today, since the Office of Information Technology is responsible for EHR's successful implementation. We are kicking off a glorious day. We are at the beginning of the beginning, and the person responsible is not here. The first transmission we get is incomplete. The ability to get documentations with the IG, who is going to have to be there every step of the way, is asking us to step in and get them information that is not being willingly given to them. That is not an auspicious start. Governance and leadership, including active engagement of senior officials with stakeholders and support of senior department executives, are critical. We don't have leaders in place to participate in the project's government or set the strategy for this project. Who's meeting with the stakeholders? Where's the support from senior executive departments? We don't have governance because critical leadership positions are unfilled. I've seen too many VA projects fail because of lack of leadership. Every one of you members of Congress own this now. If they don't do this, it's on us. It's on each of us. Last month, media outlets reported Cerner failed to effectively implement their EHR at multiple DoD facilities, citing a botched rollout that put patients' lives at risk and lacked operational effectiveness. I find the details of these reports disturbing and unacceptable. The root cause must be identified and remedied. VA cannot fail veterans again. VA and the White House must act now to remedy the deficiency so that we have qualified leaders in place before the project implementation begins this fall. Too much at stake. Veterans have been waiting too long for this seamless coordinated care between DoD, VA, and private providers. I want to thank the chairman. He understands this. That's what this subcommittee is going to do, and you can rest assured they will carry out their responsibility. I yield back.
Thank you, gentlemen, for yielding. And for the record, we did not invite the Chief Information Officer, Mr. Sandoval, and VA did not offer him to be here, and I would like to associate with your remarks with, and I agree with that. On the panel, we have Acting Secretary of Veterans Affairs, Mr. Peter Rourke. He is accompanied by leaders of the EHRM Program Executive Office, Mr. John Wyndham, welcome. The Program Executive Officer, Mr. John Short, the Chief Technology Officer, Dr. Ash Sinus, the Chief Medical Officer. On the panel, we also welcome Vice Admiral Bono, the Director of the Defense Health Agency. Welcome, Admiral. I ask the witnesses from both panels we hear from today to please stand and raise your right hand. Do you swear under the penalty of perjury that the testimony you're about to provide is the truth, whole truth, and nothing but the truth? Thank you, and you may be seated. Let the record reflect that all the witnesses have answered in the affirmative. Acting Secretary O'Rourke, you are now recognized for 5 minutes.
Thank you, Chairman. Good morning, Chairman Rowe, Ranking Member Waltz, and members of the committee. With me from VA are Mr. John Wyndham, Dr. Ashwini Zanuz, and Mr. John Short, respectively the Program Executive Officer, Chief Medical Officer, and Chief Technology Officer for VA's Electronic Health Record Modernization. Thank you for inviting us to testify. Let me acknowledge as well Vice Admiral Raquel Bono, Director of Defense Health Agency, with us this morning. In just the past 18 months, 5 major acts of Congress have benefited veterans and the VA. The Veterans Accountability and Whistleblower Protection Act, the Veterans Choice and Equality Employment Act, the Forever GI Bill, the VA Appeals Improvement and Modernization Act, and most recently, the VA Mission Act. To find another period of such significant change, we'd have to go back to Omar Bradley's days. Yet another significant step forward is electronic health record modernization. For transitioning service members and veterans, it will improve care coordination and delivery. It will provide clinicians the data and tools they need to support patient safety, and veteran data will reside in a single hosting site using a common system that enables health information sharing. So we deeply appreciate your leadership and bipartisan support. Achieving full operating capability across VA with the new EHR is a sizable task. It will take several years to complete, and we recognize and fully appreciate the challenges the Defense Department has faced in its own EHR implementation experience. So we've designed a proactive and preemptive contract management strategy. We're working closely with DoD. We're listening to advice from respected leaders in healthcare, and we're fully engaged with the Cerner Corporation regarding all critical activities, establishing governance boards, conducting current state reviews, and optimizing the deployment strategy. We tend to anticipate challenges and take full advantage of lessons learned to mitigate risk in VA's implementation. And our strategy will adapt as we learn and technology evolves. VA's EHR modernization will be a flexible, incremental process welcoming course corrections as we progress. Effective program management and oversight will be critical to cost adherence, to timelines, to performance quality objectives, and to effectively implement risk mitigation strategies. So we're committed to a PMO properly staffed with exactly the right functional, technical, and advisory subject matter expertise. To facilitate decision-making and risk adjudication, we've designed an interim governance structure of 5 functional, technical, and programmatic teams. They are the EHRM Steering Committee, the EHRM Governance Integration Board, the Functional Governance Board, the Technical Governance Board, and the Legacy EHRM Pivot Work Group. We'll continue to refine this structure and our processes over the next few months to further enhance performance and outcomes. In July, August, and September, VA will assess, validate initial operating capabilities at medical centers in Spokane, Seattle, and American Lake, Washington, as previously negotiated. In October, we'll begin EHR deployment to these 3 sites with a full capability goal of March of 2020. VISTA and related clinical systems will continue serving veterans until the EHR is fully capable. EHR modernization is deep change. It's a technical and a cultural challenge, and the human component is central to success. So we'll fully engage end users early to train facility staff and promote successful adoption. Clinical councils of doctors, nurses, and other frontline users will support workflow configuration, and they'll help identify staff concerns and propose responsive solutions. VISNs will have the opportunity to configure workflows without customization based on their unique circumstances, and will continue to work with our DoD counterparts to help navigate joint costs, schedules, performance, and interoperability objectives. It's a user-centric approach to a veteran-centric change. VA's electronic health record modernization represents a monumental improvement for veterans, possibly only with the strong support of the President, this committee, and the Congress, veteran service organizations, and other stakeholders. Thank you for honoring our nation's commitment to veterans, and I look forward to your questions.
Thank you, Mr. Secretary. Admiral Bono, you're recognized.
Thank you, sir. Chairman Rowe, Ranking Member Walz, and distinguished members of the committee, thank you for the opportunity to testify before you today. I'm honored to represent the Department of Defense and discuss the Department's experience in implementing a modernized electronic health record, EHR. And I'm excited about the tremendous opportunity we have to advance interoperability with the VA and private sector providers as a result of the VA's recent decision to acquire the same commercial EHR that the DoD is now deploying. The decision by DoD to acquire a commercial EHR was informed by numerous advantages, introducing a proven product that can be used globally in deployed environments, as well as in military hospitals and clinics in the United States, leveraging ongoing commercial innovation throughout the EHR lifecycle, improving interoperability with private sector providers, and offering an opportunity to transform the delivery of health care for service members, veterans, and their families. In 2017, the department deployed MHS Genesis to all 4 initial operational capability IOC sites in the Pacific Northwest, culminating with deployment to Madigan Army Medical Center, MAMC, the largest of the IOC sites in Tacoma, Washington. The other sites include the 92nd Medical Group at Fairchild Air Force Base, Naval Health Clinic Oak Harbor, and Naval Hospital Bremerton, all in Washington State. Over the next 4 years, MHS Genesis will replace DoD legacy healthcare systems and will support the availability of electronic health records for more than 9.4 million DoD beneficiaries and approximately 205,000 MHS personnel globally. By deploying to 4 hospitals and clinics that span a cross-section of size and complexity of MTFs, we have been able to perform operational testing activities to ensure MHS Genesis meets all requirements for effectiveness, suitability, and data interoperability. Right now, we are in the midst of making important improvements to software, training, and workflows, addressing the lessons we learned in the initial deployment as we prepare to continue our deployments into 2019. End-user feedback to our changes have been relatively positive. Our success is dependent on strong clinical leadership, both here in our headquarters and by clinical champions at the point of care. The department is focused on maintaining this clinical leadership as we move to the next deployment wave. To best support MHS Genesis, the Defense Health Agency is also fielding a cost-effective communications infrastructure and network throughout the military health system. When completed, DoD medical providers, whether they are affiliated with the Army, Navy, or Air Force, will be able to use their Common Access Card, CAC, into any computer on the DoD healthcare network and access their identical desktop as they travel from one location to another, inside or outside the continental United States. We have also optimized our network to help ensure continuity of care for our beneficiaries. Over the past 5 years, DoD steadily increased its data sharing partnerships with private sector healthcare organizations. Today, DoD has nearly 50 health information exchange partners in the private sector. Since award of the VA contract, leaders from both departments have been meeting to more formally integrate our management and oversight activities. We are sharing all of our lessons and future planned deployments with our colleagues at the VA and plan to synchronize deployments where possible. The VA and DoD understand that the mutual success of this venture is dependent on our continued close coordination and communication. Thank you again for the opportunity to come here today and share the progress we've made to transform the delivery of health care, as well as discuss the opportunity to strengthen the DoD-VA partnerships as we move forward together with a common EHR that will benefit millions of service members and veterans. As a partner in our progress, we appreciate Congress's interest in this effort and ask for your continued support to help us deliver on our promise to provide world-class care and services to those who faithfully serve our nation. Thank you for this opportunity, and I look forward to your questions.
Thank you, Admiral, and thank all of y'all for being here. And this is, first of all, I want to thank the members for being here. This is not the kind of hearing that you're going to go home to the Kiwanis Club and say, I'm going to talk about the electronic health record. People are going to start looking at their watch and heading to the doors. But it is incredible. I know this personally. It is incredibly important that we get this right. And one of the things, I've only made one visit to begin to see the rollout, but I intend to make others as quickly as I can. And one of the things that first, to make this all work, we spent a year and a half doing a VA Mission Act, where people get that can't access care timely, or whatever the reason is, maybe they live in a rural area, that they access care outside the VA. It's incredibly important that these health information exchanges work, that we can share information. It's a problem in the private sector, trust me. I mean, you can't go to your hospital and get the information, you can't get a lab test. One of the things that bothered me when I was out at Fairchild was on MHS Genesis. When you came in, what was entered into the EHR was basically allergies, medications, procedures, immunizations. I can get that in 1 minute of asking somebody. Other data, which included what I really want to see, are your lab results, x-ray reports, notes from previous visits, discharge summaries. You have to use the Joint Legacy Viewer to look back. And my question is, are provided, that slows you down. I've told people all along, if you're in a busy practice like I was and saw 25 people a day, you took 2 minutes is all. It added 2 minutes to each patient. I'm an hour late at the end of the day. And you've frustrated people. The doctors and nurses are staying after hours to fill in the reports. So are we going to be, Mr. O'Rourke, you can answer it, any of your team can, or Admiral Bono, you can, are we going to be able to put all this information in where the practitioner, the nurse, and the other providers are able to access it without using two systems? And if we do, what's the point of using Cerner if we have to keep two systems live? You've then got the cost of the old system, which I think is about $1 billion a year. And then what would be the cost of the new system, Cerner, to maintain it? If we've just added cost and hadn't added value, we haven't added much. So I'll start with Admiral Bono.
Yes, sir. Thank you very much. And you're exactly right. You've described that perfectly. And so one of the things that we did is we embedded the Joint Legacy Viewer within our MHS Genesis so that it's just within there. People in the past had to log out, log in, contributing to the time. Now it's a click within the MHS program because having access to that information that we put in the Joint Legacy Viewer, that's not only a part of the care that people may have received in VA hospitals, but also in the private sector is incredibly important to the continuity of their care. So what we did is we've embedded it into MHS Genesis.
Well, especially for you all at DOD where 60% of people
yes, sir.
They get their care outside the Department of Defense, that information doesn't flow.
Yes, sir. Bad
results happen. Will the VA be able to do that, Mr. O'Rourke? Be able to put all, because basically the people I saw at Fairchild are healthy airmen. I mean, they're young, healthy people for the most part. If not, they're not in the military. So will the VA be able to take these very complicated medical records, which have, I mean, many patients are ill and older?
Absolutely. Our goal is to make sure that we have seamless data transfer and all those different aspects. But I'm going to let Dr. Sweeney address that specifically.
Congressman, we understand at the VA as well as at DOD that a complete longitudinal record is the ultimate goal. And as part of the lessons learned from not only the DOD implementation, but our use in the VA with JLB and external implementations, when we go live at our Cerner sites, Cerner implementation sites, we will have a single system that ingests all of the records, not only from DOD, anything that's coming in, but also from our community providers into the appropriate place for a long record. That is above and beyond the PAMPI data that you just noted. That'll include notes, clinic notes, laboratory exams, radiology exams, and much more.
Well, that's a robust, because we're talking about March of 2020. And hopefully most of these members will still be sitting here in 2020 if they desire, but that's not that long. If you're starting in October, we're almost at that point, almost in 2019. So you're looking at an 18-month rollout in the Northwest. Would it make sense to roll out Great Lakes, which is where you have a combined VA DOD facility? Are you going to roll that out simultaneously? And I know that may not Admiral Bono, that may not be in the works, but it seems like that would make sense.
Yes, sir. I think that by working with the VA, we have identified areas where we do have some synergies that we want to capitalize on. We've certainly looked at the Great Lakes area. I know that there are some infrastructure things that we have to address there, but I think that would be an opportunity we definitely want to explore.
The other thing I'd like to ask, are you all working together, sharing this information so we don't recreate the wheel? And what I'm asking about that is, I think when I read in DOD, the people on the ground, the people that are every day, I got to click this thing on and try to make it work. They didn't really know who, when they had a work order or something, they needed an answer to a question. They couldn't get to answer that question. It was basically, there was one, like me calling a prescription to one of these large drugstore chains, 1-800-HOLD. So it basically, that's what was happening. It looks to me like they couldn't get an answer, so they had to do a workaround. Have we learned things from that so that the people actually implementing this thing that you know, their stomach is hurting, they're taking another Zantac because of it, do they have a way to get an answer quickly without going through back to D.C. and through this big hoop?
Yes, sir. As a matter of fact, based on the feedback that we were getting from the end users, as well as the report and observations that your group was able to share with us, we have put in place a more streamlined process to be able to address these. And we have stood up an Office of Chief Health Information, and what that does is allow us to make some decisions closer to the actual site.
Yeah, that'd be the trouble ticket resolution. If
Yes, sir.
If you're sitting there, and it said DOD is making adjustments to software training and workflows. What adjustments have you made?
Yes, sir. So some of the training is extremely important, and we realize that, and that is one of the lessons that we have shared with the VA. Training has a large part to do with the change management, and as I think you mentioned, it needs to be something that the providers can easily adopt to, and I think that's one of the pieces that we've learned, is that the providers need to be very much a part of that training and that change management. And so the workflows that we've introduced have to reflect what best supports the clinical practice.
Okay, my time's expired, Mr. Waltz.
Thank you, Chairman Rowe. I want to get us all on the same sheet to start with. So, Mr. O'Rourke, let's clear this thing up in the beginning. I want you to guarantee me the IG will immediately have access to that Office of Accountability Whistleblower Protection database and any other information it needs to audit that program today. Can you give me that assurance they can have all the data they asked for?
Absolutely, sir. The IG has had access to any information in the Office of Accountability that he would request appropriately.
That's not the understanding.
So there's just one thing to clear up. The information that we protect in the Office of Accountability is privacy information, and just like this committee with the accountability law prescribed, was the privacy of whistleblowers, which is sacred to us in the office. Privacy of whistleblower identities is specifically called out in the accountability law that it cannot be shared with anybody, including the secretary. I can't even see it at this point in my current role unless given written authorization by the whistleblower. Now, that is a Privacy Act now record that applies in Title V, which only requires that the IG request. It doesn't have to provide a reason, just has to say, I would like this information, and he'll be provided that. That's all we've asked for. In fact, we took the extra step. One of the things that I tried to do as the executive director, which was to have a liaison from the IG in the Office of Accountability to review these records as we received disclosures. It wasn't something they were interested in at the time. That's fine. It's up to their discretion. But that request only needs to be made so we can, both Title V and the accountability law, be covered, and he can have any information that he'd like.
We'll get back with the IG today.
Absolutely.
And make sure that they're satisfied and we get in and we get that done. That's great. And I understand why Chairman Rowe said Mr. Sandoval was not invited here. The thing I would mention to you, Dio, is at the heart of the single biggest electronic project maybe we've ever done in government, we haven't received one phone call, one text, or one interaction at all with Mr. Sandoval at the people who are involved in this.
Sure.
So my team. So we need to know who to contact. And again, we have a new office set up. The only contact was you. Do you want the staff to go directly through you, or is there someone over there manning that? Is there someone we can contact to talk to about the issues?
Absolutely. This team that's with me here today is leading up the core part of that new office. As we stated and as we talked about in the opening statement, we're continuously improving both the structures and the approaches. And that's how we're going to approach this entire project. We're going to share that with you as many times as we have the opportunity, and we're excited, frankly, with the Special Oversight Committee.
Can they send us the attachment?
Absolutely.
Okay. I want an assurance, too, that the GAO will have access to the officials and the contractors involved in the project. Can you assure me that GAO will sit in on those governance meetings and be allowed to review the quarterly reports?
Absolutely.
At will? All
Absolutely.
Right. So setting up that governance board, now that the contract's out there, I'm assuming that it's in place. Who will be part of the 5 project governance boards, and how often do they meet? We're just unsure of how that's going to function. Sure. And what's there, who's on it, how it's been done. How far, in your assessment, on that process are you?
Well, I think it's helpful for you to see how the leadership's looking at this. We know, and we agree with both you and the chairman, that leadership has to be involved in this, although this can't turn into some top-down implementation. So I know for me personally, I'll be involved. We've set up not only the governance boards, we've set up overall management boards where we're looking at all of our priorities, this being one very specific. And so we're bringing the entire VA senior leadership team to view these projects. Now, specifically for the governance boards, John, do you want to give him some more specifics?
Yes, sir. As we assessed potential governance actions, it was important to have a cross-functional team composing these governance boards. So you'll see representation from the field, probably most importantly, but also from headquarters, from OI&T, from VHA, from other representatives, and it's often an issue-dependent makeup of the board. So we'll ad hoc members of the board based on an issue in particular that may be at hand. Those boards are set to meet. Again, I need to emphasize that governance has to take place at the lowest level. We can't escalate things continually to the Secretary's office, otherwise we're failing. And so we don't intend to fail. So we'll be managing these governance evolutions at the lowest level. To my left, Dr. Ashley News, she leads the Chief Medical Board, and to my right, John Short leads the Technology Board. So again, cross-functional membership, timely resolution will be imperative for our boards to be successful.
Well, I'm hopeful. I know no one intends to fail, but I've seen it. We're going to have to find out what your full-time needs are and who's been staffed into that. The thing I'll say, and it's probably not for this group, if this is a higher level, but we still don't have a confirmed secretary, deputy secretary, undersecretary for health, or chief information officer. Pretty important that those positions be filled with some stability. I pass that on for anybody who's listening, or if you got a direct line to the person who can nominate and get those done, that would be great. So yes, I yield back.
Thank you, gentlemen, for yielding. Chairman Boss, you're recognized. 5 minutes.
Thank you, Mr. Chairman. First off, let me tell you that I agree with the chairman on how important this is. One of the biggest shocks that I had whenever becoming a member of Congress was working to try to get the medical records simply transferred from DOD into Veterans Affairs, which is just amazing to me in a nation of this size, and that it has taken us this long. Of course, you got to remember, I came from a time when I left the Marine Corps, my medical records were on microfiche. So now we need to step forward. But Mr. O'Rourke, I need to find out, you know, the commission on CARE report issued June 30th, 2016, recommended that the VHA produce and implement a comprehensive commercial off-the-shelf information technology solution to include clinical, operational, and financial systems that can support the transformation of VHA. I believe this is a good thing, and that the VA has finally listened to the recommendations after a few years, but it does not seem as though the VA has already, it does seem as though the VA is already experiencing some delays during the contracting phase with Cerner. How does the VA plan to work with Cerner and DOD to ensure that the implementation timeline is met?
Sir, that request to us to transform VHA was one of the things that has driven us to look at every aspect of our healthcare delivery system. So I can assure you that we're taking that charge very seriously. When it comes to working with DOD, I think we've talked this morning, and I think by having the Admiral here this morning with us shows that we are hand in hand with DOD to make sure that veterans are served from the time that they sign up on active duty to the time that they come to the Veterans Administration for service. We're not going to run away from that challenge. We see that it is one of the more important things that we have to face today. So I can assure you our full leadership team is involved in making sure that we address those issues.
Okay, I think that's what's vitally important to this committee, because many of us see as you move forward, when we hear reports and the questions that are out there, the big fear we have is those those dates are not going to be met. And we want to make sure it's done right, but we also want to make sure that it's done in a way where the American citizens can actually, our veterans can actually see it come to pass in a quick and efficient manner. Kind of on that, but is my second part of my question. According to an article on military.com, it appears some of the hospitals implementing MHS Genesis have been experiencing delays, especially at the pharmacies. Has the VA discussed with the DOD ways to avoid these increased delays due to the EHR and its systems?
So we've been reviewing those reports and actually the documents that we share together with the DOD continuously since we've started this process. So we're aware of what the issues are there, and we've worked together to provide our input on those solutions, but also taking what the DOD has done to solve those issues as well, and integrated those into our plan.
Just for me knowing, how many staff do you have working on this at this time, and Is it a large group, or is it pretty well turned over to Cerner? Or?
Well, we're not going to turn everything over to Cerner. We will have our internal team built. As you know, we're continuously developing that org structure and what's going to be the best to not only make sure that we have top-level oversight from a management standpoint, but also have the right governance and the right decision-making being happened at the deployment sites and then also in our program executive office.
Thank you. Mr. Chairman, I yield back.
Thank you, gentlemen. Yield. Mr. Takano, you're recognized.
Mr. O'Rourke, I first want to echo the concerns raised by Ranking Member Walz. While serving on this committee, I quickly learned the important role the IG plays in helping Congress to provide proper oversight of the VA and ensure that veterans are getting timely access to the benefits and care they deserve. The independence of the IG is absolutely crucial, and proper oversight will be extremely important in the years to come as VA undertakes the massive endeavor of updating its EHR system. I believe the Senate expressed itself unanimously in a funding bill on this issue. But to the matter at hand, the GAO identifies involvement of senior agency officials as a fundamental practice necessary to the successful acquisition and implementation of the EHR. We also heard at the hearing last week on staffing that having strong leadership in place is crucial for the success of a new initiative. Mr. O'Rourke, where is the VA in the process of identifying a qualified Deputy Secretary, Undersecretary of Health, and a Chief Information Officer?
I completely agree with you that that senior leadership involvement in these is absolutely critical for success. Take a look at any implementation with a leadership that is not there.
I get that. My time is short, but just tell me where you are. Where are you in the process? Have you been interviewing people? When can we expect these positions to be filled?
For the Deputy Secretary, that's something I'll have to defer to the White House. That's a decision that they make on who they're going to pick for those senior leadership positions.
Okay, and what about the Undersecretary of Health and the Chief Information Officer?
So for the Undersecretary for Health, there's a process for that with the Commission. So we will be conducting a commission here very shortly.
I remind you, we're undertaking a $10 to $15 billion initiative, and we don't have these critical positions filled.
I agree.
How many FTE are needed to fully staff the Project Management Office, and how many positions remain unfilled?
I can assure you that we're going to have the appropriate amount of FTE for that specific question. I'll turn it to John.
I'll touch on that, sir. We have 260 identified as our organizational requirements at this phase. We expect that to grow as we obviously implement to more sites. Right now, we have the requisite technical expertise on staff or access to that. Field support is imperative in this effort, and so being able to reach out to the field component, and so I would defer any additional comments to the Chief Medical Officer.
Okay, no one's given me a number. How many are FTE are really needed here?
260 for the next phase, sir.
Okay, and how many positions remain unfilled of that 260?
At this point right now, sir, the staffing is over the period of time. We have the 135 clinicians that we need in-house to conduct
It's a simple answer. You gave me a direct answer, 260. How many of the 260 remain unfilled?
35, sir.
So you filled 260 minus 35. I can't do the math in my head.
Sir, the fill rate is, again, accessibility is important. It's an imperative that we don't disrupt the care being delivered to our veterans today. So we are accessing field support from their respective activities. So again, the important thing is that we have access to the requisite knowledge, whether it be clinical or technical, and we have that at this stage.
All right. So you said all but 35 have been filled.
35, sir. And those are likely permanent hires, full-time hires, that the hiring process is presently being...
Well, so just to be clear, 35 positions remain to be filled.
Yes, sir.
Saying? Okay. All right. Well, that's better than I thought. All right. Has the VA DOD interagency working group met?
Sir, the interagency working group has met to solidify its governance processes. So that's an ongoing process. We've been meeting, we meet formally monthly. We meet routinely every Friday, and we meet
So you have met, who attends these meetings? Who attends the meetings?
Sir, I lead the effort for the VA side, and Stacy Cummings, who is the PEO for the DIMS effort, or the MHS Genesis effort, leads on the DOD side.
And you did give me an idea of how often it meets. It meets how often?
It meets monthly, formally, all-day session monthly. It meets every Friday for approximately 45 minutes, and it's continuously amongst the field experts and the clinicians and the technicians that are working specific issues.
I'll just conclude my time by just saying that I don't see how this is going to end well unless we get the top leadership positions in place, and that these folks that fill, especially the Chief Information Officer, is a highly qualified individual to oversee this project. And it's not on you, it's on the White House for leaving these positions unfilled, especially when we have this massive, massive contract that we've got to oversee.
Yes, sir.
Thank you.
Thank you, General Yield. Dr. Dunn, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman, and thank the panel for coming today. I know it's, I can imagine how much fun it is to be here. So I want to say at the outset, I'm a physician. My career spans the period of time began with handwritten notes and faxes were a new invention back then. So now we're in 5th generation EHRs. I've lived through EHR purgatory on multiple occasions and spent a great deal of my own office's money on EHR, so I'm certainly sympathetic and I understand the size of the project that we're taking on. I want everybody here to remember that fundamentally, most importantly, what we're doing is not building an EHR. We're taking care of our patients, the veterans, that our goal is quality, timely care for veterans. It's not to have, you know, the best EHR that's ever been invented. So with that in mind, let me start, if I may, Mr. Secretary, I know you have a deep experience at the VA and in other organizations and in health. Can you address what you think are some of the barriers to and challenges to implementing this, this new EHR?
Thank you. What we face, as you said, is a historic opportunity. I think everybody at this table is committed to the outcomes for veterans that we all desire, which is a great healthcare delivery system, benefits delivery system. We see this opportunity as the next step in that journey of being able to provide veterans exactly what they deserve. We all come to this with somewhat of excitement and a sense of being able to be on the front end of history of what we see as an opportunity that's doesn't come along once or twice in a generation. So we're looking forward to that. From anything that's standing in our way, I really don't see that. I think we've gotten the support from the Congress that we absolutely need. That'll come in the form of oversight, working with us, taking on anything that we see as a problem for us. But you know, when it comes to just communication between us and you all, amongst ourselves, with DOD, those are really going to be what we face.
So we have a historic opportunity to succeed or fail, and certainly I want you and your team to keep us informed about what we can do to push the needle towards success. How are we explaining this to the average, all your clinicians? You got a lot of doctors and nurses. How are you explaining to them the benefits of this change?
We understand this is going to be a deep cultural change, but luckily I have a chief medical officer here that can provide some more detail.
Dr. Zanus, go ahead.
Thank you, sir. We understand that this is requires a cultural change and that this is first and foremost a business transformation more than just an IT project. So with that in mind, change management is #1 on our list. We have a robust change management plan that not only involves training, elbow-to-elbow virtual sessions, et cetera, but we have also involved the field at the very beginning of the process here.
That's good. I was going to ask you about that. So is there, your doctors, your nurses, your clinical specialists, they're actually involved in helping design the interface and also what you need to have in the way of information coming out of that?
Correct. They will be involved not only in designing, but will also lead the way in as we go forward.
So, and to Admiral Bono, we say this is interoperable between DOD and the VEHA. Will it really be? I mean, I'm a doctor in the DOD. I'm doing a medical record. I walk over to the VA. Would I be able to recognize and operate the system over there?
Yes, sir. I think that's one of the benefits that we've got here. It's a single instant of the EHR record. So it is the same. It is the same product.
Same interface.
Yes, sir. And that's why we're very invested in their success, because it'll mean our success as well.
So this really would be a first time. I've worked in I don't know how many hospitals, how many clinics, and every single one of them has a different interface, and it's maddening. I can tell you, it's a reason to actually constrict where you work. I have this for Secretary O'Rourke. The VHA clinicians, are they actually already being prepared for this standardization? Maybe that should be to you, Dr. Zanuz.
I know that we're making it a regular component of leadership communications with the field. I know every visit that I take to a medical center director, we're making this a topic of discussion, preparing our clinicians, our leadership at the local levels for what's coming, and providing them a positive outlook. It's going to be hard enough, as Dr. Aswini mentioned, is with the cultural change. So we're working very hard with what we can do at our level to make that
Well, my time's about to expire, but I do want to encourage you to work with the clinicians very, very proactively. You mentioned a cultural change. It's a huge change for them, and they're focused on their patients, and they think that sometimes we irritate them with the EHR changes. I yield back, Mr. Chairman. Thank you.
Thank you, gentleman, for yielding. Ms. Brownlee, you recognized for 5 minutes.
Thank you, Mr. Chairman. So where does the buck stop on this implementation plan?
with me.
And when a new secretary is appointed, there'll be a transference of information and to the new secretary?
That's a very good thing to point out, because I think it goes back to an earlier question. Without a deputy secretary, and it's very clear right now that the deputy has a pivotal and a critical role in this. Right now, without one, that rolls up to the secretary. It'll stay with me until we have a new nominee confirmed, and then it'll be with him until we have a deputy secretary in place.
Thank you. So I've been on this committee for 5.5 years, and one thing that I can say based on historical experiences is that lack of leadership or turnover in leadership has caused delays in almost any endeavor that has been undertaken. And so I think I share the concerns of many on the committee that, at the outset we're worried about various deadlines and meeting the interim goals as we move forward on this. The early timeline, the chairman mentioned the preliminary plans to include an 8-year deployment schedule, beginning with the initial implementation sites within 18 months of October 1. Concerned about that. Also, I understand that there is an ongoing development of that the VA is working on life cycle cost, on data migration, a change management plan, and an integrated master schedule to establish key milestones over the life of the project. So I think the GAO reported that the department intends to complete the development of its initial plans for the program within 30 to 90 days of awarding the contract and that's between mid-June, mid-August of 2018. Are you still on schedule to meet these deadlines?
As we discussed earlier, we're working on those planning and development of those milestones over the next through July through September this year.
And so, when do you know now when the first sort of key milestone will be? And
having our IOC plan to start on October 1st.
Then the second milestone.
The second milestone will be getting to an initial operating capability at those initial sites.
Okay. Well, I just, I'm not sure what the driving question is here to get some assurances, but certainly meeting those first couple of milestones, I think is going to be very important in terms of reassuring this committee that we are indeed on track with this implementation. And as has been already stated, this is obviously an extremely important endeavor that we've invested a tremendous amount of tax dollars into, and our desire to be successful. And I will just reaffirm what others have already said, is that the the lack of leadership or the turnover in leadership right now is a major concern. The last question that I just wanted to ask you, Secretary O'Rourke, is that I know earlier this year there were some reports that signing the Cerner contract was delayed based on sort of outside non-governmental individuals were attempting to influence perhaps the use of commercial off-the-shelf electronic health records rather than proceeding with this Cerner agreement. Can you just assure the committee and assure me that that you feel that your work is really free from any undue outside political influence?
Absolutely. As you all know, I became the chief of staff in an interesting time, and one of the key tasks I had at that time was to bring some sense of order to the department at a time when we were struggling in some ways. One of the key things that I focused on very quickly was the EHRM process, I guess, if you can call it, at the time, and seeing where it was and how do we get it finished, because I knew from this committee's perspective that they wanted to see a result. So I became very involved in making sure that we were pushing toward the right result. So I would not characterize this as anything other than providing the best product for veterans, which we knew was going to be, like we talked about, a historic opportunity. We weren't about to let that be changed in any way and demystify that.
Thank you. My time is up. I yield back.
Thank you for yielding back. Mr. Higgins, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Secretary O'Rourke, thank you for your service to your country, sir. I'd like to dive deeper into what the ranking member had asked you about regarding GAO and IG records requests. We're all pretty much universally concerned about transparency in government, and there's no more opaque alphabet branch of our government than the VA, historically. So we have a greater responsibility to be more transparent, more reflective of the will of we the people in service to the veterans that we are dedicated to, my brother and sister veterans. It's more crucial that we're completely transparent regarding our reactions to whistleblowers and requests thereof. My understanding is there's a proposed rule in the VA to amend the Department of Veterans Affairs regulations governing the submission and processing of requests for information under the Freedom of Information Act and the Privacy Act in order to reorganize, streamline, and clarify existing regulations. Is that true?
I'd have to take that back for the record. I'm not personally aware of that.
Okay, specifically regarding the confidentiality of whistleblowers' data, it just seems to me that if the IG or the GAO has requested data, and that would include some whistleblower information, it seems to me that could be redacted, but that there can be no guarantee of confidentiality for whistleblowers. Certainly, none of us in America, certainly not in this committee, we don't want the VA investigating itself. We don't want the DOD investigating itself. We don't want the FBI investigating itself, and we don't want the VA investigating itself. The GAO and IG and the committees like this are bound by oath to perform those tasks. And from the U.S. Director of National Security Government website, in a question and answer segment regarding the question, how realistic is it that I'll maintain my confidentiality? It says on our website, at some point in an inquiry, it may be necessary to reveal your identity to further the whistleblowing process or as otherwise required by law. Additionally, depending upon the nature of the inquiry, the information disclosed may make your identity obvious despite all precautions taken to maintain your confidentiality. So please explain to us, and I ask you this respectfully, sir. I understand you have a job to do. I was a police officer for 14 years. I understand internal investigations, but this is the VA, man. We have major problems here that's our responsibility to fix. And our investigative services for government branches that respond to whistleblower data, if they request that data, they need to get it. So please explain to us what you had stated regarding whistleblowers having to give permission for their data to be revealed.
I'll do it very concisely. It's very clear what the accountability law states about the identity of whistleblowers and what that, who and how that information is revealed or shared. Privacy law, since we keep that information in a system of records, Privacy Act law covers that information. It's for all those entities that need that information, it is a simple written request. They don't have to provide a reason, they don't have to provide an excuse, they just say, we want this data, provide it, and it's provided without redaction. The only
does the answer to in the question and answer section on the U.S. Director of National Security government website, does that reflect the reality that you're explaining today regarding government employees questioning their confidentiality if they bring whistleblower data to a supervisor?
When they bring it to their supervisor, there is a less of a hold on their privacy, because they're bringing up the disclosure that's maybe process-based or things like that. Retaliation, things of those nature, when they're disclosing those, have to have their names attached to them. Otherwise, you can't prove the retaliation.
Doctor, you had something to add? You motioned to, did you raise your hand, madam?
They're both from the HR program. I'm the guy, I guess, to answer the questions about accountability.
All right, Mr. Chairman, my time has expired, but I'll have a written question to submit to the panel if that's within the parameters of our authority, sir.
It is.
Thank you.
Ms. Custer, you recognize.
Thank you very much, Mr. Chairman. I noticed at the outset that our chair was quite clear that he had not included Acting Chief Information Officer Kamalo Sandoval in the invitation to be here today, but I just want to note for the record that it does trouble me. This is not the subject of this hearing, but I can't pass it up to say that the Merit Systems Protection Board study has found the Veterans Administration as having the highest incidence of sexual harassment across all federal agencies. I won't get into the details of Mr. Sandoval's situation, but do you have confidence that Mr. Sandoval can accomplish his mission, which is so crucial to our veterans all across this country? Many of us joined this hearing, this committee 5.5 years ago. Our very first hearing was about the fact that we could not communicate between the Department of Defense and the VA. We're spending millions, hundreds of millions of dollars, and yet the very person that is supposedly in charge is not able to focus on his duties because of allegations during the campaign about sexual harassment.
I can't address what's in, I guess, in a lawsuit, but I can tell you that we're setting up.
Well, can he get the job done? Should he be replaced, and is he being replaced? How are we going to get the job
I have
done?
a lot of confidence in Kamalo Sandoval and what he's been able to do as the
Is he
executive
on the
in
job
charge.
to get the job done?
Absolutely. He's been finding and been working with us to find and restructure the Office of Information Technology because of some of the poor leadership that it's had in the past.
But if he loses his job because of these allegations, do you have another plan?
If the president decides to remove a political appointee, then we will have somebody else step into that role, just like he stepped into that role when the previous executive in charge left.
It just seems that with an acting secretary waiting for confirmation, with a number of these offices that we've all discussed today, including the Chief Information Officer, I just have to note for the record, we're not putting our best foot forward on this project, and it's a disappointment. Admiral Bono and Mr. O'Rourke, can you please describe how you hope to use the Cerner EHR to improve the management of pain and opioid prescriptions with our nation's service members and veterans?
I know that there are some unique features within the Cerner product that help us provide that kind of oversight.
Is there anyone on the panel that could describe those features?
And I'm going to pass that off to my Chief Medical Officer.
Thank you very much.
Thank you. One of the main components of the Cerner plan for opioid risk is a risk stratification tool. It not only brings in all of the information from the various PDMPs, the prescription drug monitoring programs across all of the different states that participate in it. It brings it to a single place so that our providers have it at their fingertips, but also gives them a scoring for the patient's risk for opioid abuse. So it takes it not only from the community providers, VA prescriptions, but also any input that we get from the military of history of opioid prescriptions for the patient. So
good. I'd like to be kept apprised of the progress of that and any results or data or findings if there's research on how that's been effective. You mentioned
Absolutely.
Community care, and another concern that I have, one of the largest concerns with interoperability is with the VA's community providers. What are Cerner's current plans to facilitate interoperable functionality with community care providers?
Absolutely. We recognize that more than 30% of the care in the VA is delivered in the community and that we need to have our providers across the care continuum have access to all of the data. Our goal is not only to have data that's available to them through current practices, but to build on it, whether it's our 168 HIEs that we're currently using, that we participate in, direct messaging, provider portals that we provide to the community, but also have the ability for the providers inside and outside of the VA that participate in the care to have the analytics tools and the registries available to them so that they can participate and improve the outcomes of the patient.
That's another piece that we'd like continual monitoring on.
Absolutely.
My time is short, but just briefly, if the community provider does not use Cerner, can you have an interoperable function?
Yes, absolutely. We have health information exchanges that we participate in. We have a network of 168 that we partner with currently, so it doesn't have to be Cerner. It could be any of the other EHR systems and record sharing systems that they use. If the community providers...
My time is up. I apologize. I truly don't like being rude, but I know I need to yield back. Thank you, Mr. Chairman.
Thank you, the gentleman for yielding. Mr. Banks, you recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Wyndham, I was much confused a moment ago as you were answering Mr. Takano's questions about the interagency working group. Have you met more than once just to discuss governance, as you put it?
Yes, sir. We've been meeting for the past year as we negotiated the Cerner agreement. We knew governance would be imperative. So
How many times have you met? How many times have you met?
I would estimate somewhere around 6 or 7.
On a monthly basis?
Correct.
Do you speak with your colleague more than once a month? Or do you only speak with your colleague during the interagency meeting?
No, we have a Friday call, standing Friday call at 11 a.m., and we also have continuous interactions at the technical and the clinical levels. That's where the hard work is really being done.
Okay, thank you. Mr. O'Rourke, an article was published at the very start of this hearing, just a little bit ago, stating that Genevieve Morris, who is seated right behind you, will be leading the EHRM office. If that's true, when was that decision made and why isn't she testifying today?
It's premature reporting. We were going through the process of actually setting up an industry standard structure for these kind of implementations, which uses more often than a chief information officer, a chief medical information officer. Ms. Morris has been instrumental with helping us through really the past few months. She's been loaned to us from HHS and has been critical to this team and has helped us with some broader perspectives of the industry and successful ways of implementing this project.
So she won't be leading the office?
We're evaluating that chief medical.
Premature, perhaps inaccurate reporting?
The accuracy of it is, definitely she's a candidate for that job. She would be perfectly qualified for that.
So to be determined?
To be determined.
Okay. Mr. O'Rourke, in your testimony, you state the VA structured the IDIQ contract to, quote, provide maximum flexibility, end quote. Can you explain what that means and what freedom and flexibility the VA has?
Early on, we were very concerned about being tied to a specific set of boundaries when it came to these kind of implementations. So we were very intent in the negotiations that John led to make sure that the VA has the primacy in making decisions on where we go with this and not be stuck with the contractor driving us to decisions we may or may not want to make. So we were intent on making sure that flexibility was there.
So how can you use that contract flexibility to respond to hurdles during the implementation? For instance, if the planning takes longer than expected or the implementation in the initial sites don't go as smoothly as expected?
I'd like to have John Wyndham specifically talk through that.
Yes, sir. IDIQ stands for indefinite delivery, indefinite quantity. The way that works is task orders are issued in support of the foundational contract such that you can issue task orders to increase timelines, increase scope, increase the wave deployments, or you can restrict task orders to more control in support of cost, schedule, and performance objectives, and obviously the management of risk. We never want to bite off more than we can chew. We understand the importance of our veterans and the care we deliver, and therefore we want to make sure we optimize the use of that IDIQ vehicle in delivering those support services that we anticipate being able to deliver.
Okay, thank you. Mr. O'Rourke, can you assure me that the EHR modernization will result in one and only one EHR system?
That is definitely our intent.
That would include for interoperability purposes and to access the legacy data. And can you confirm to me that once the Cerner Millennium EHR is implemented, the VA will completely stop using Vista and the Joint Legacy Viewer?
It is our intent to not use Vista. The Joint Legacy Viewer, I think, may need some life cycle, but we're still in that planning part.
But that's your intent?
Yes.
Okay. Admiral, how is this dynamic working in MHS Genesis? Will Cerner completely replace CHCS and Alta?
Yes, sir. That we are going to transfer all of our functions onto the new electronic health record, MHS Genesis, and sunset the legacy ones. We will still maintain some connection to our legacy databases, but in terms of the legacy applications and programs that are associated with Alta and CHCS, those will be sunset.
So that's a definite, not just and that's not just your intent, that's definite.
Yes, sir.
Okay. Thank you very much. I yield back.
Thank you, gentlemen, for yielding. Ms. Rice, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to direct my questions to you, Mr. O'Rourke. So before you were in the position that you presently hold, you were actually the first executive director for the VA's Office of Accountability and Whistleblower Protection, right?
Yes.
And you did that for approximately how long?
From when we stood up the office in May through the time I became Chief of Staff.
So that was what kind of time period?
Through, I believe, February of this year.
And you would agree that in that position, which I believe is the first of its kind in any governmental agency, a large part of your duty there was to ensure a level of accountability?
Yes, it was. It was to implement the new accountability and whistleblower protection law and to set up the new office.
So can you just go back again in your thought process in terms of not wanting to respond to the OIG's request for that information?
I think the broader story should be told on that. From day one, we realized that the relationships between the Office of Special Counsel, the Office of Investigator General, and others, frankly, in this committee, were not good. There was previous offices within VA that had this responsibility to investigate senior leaders, did not have a great track record. It was my intent early on to break through those barriers between those very important entities, that all had their statute-driven mandates, to make sure that we were all working together to protect whistleblowers first, and to make sure that we were investigating misconduct and holding people accountable. With the IG, that took the form of trying to find some creative and new ways to work together. There's some hard walls you can't cross with the IG, especially when it comes to criminal activity, those kind of things. Those are not investigative responsibilities of our office that we were starting up. That's where we would partner with the IG, but as you can appreciate, a lot of things that happen in the VA cross different boundaries. And holding a senior leader accountable is sometimes a complex situation. So we wanted to work closer with the IG, especially when it came to disclosures, because part of the accountability law actually puts the weight on the Office of Accountability to review IG-received whistleblower disclosures.
Right, but the problem is in the past, and we've heard this time and time again here on this committee, is that the VA is incapable of holding anyone accountable in their ranks. And so it's essential that you have a body like an OIG to be able to look into allegations, whatever they may be, and be able to do that in an independent way. You made, to me, what I thought were disturbing statements about how the OIG actually works for you, and you are the supervisor of the OIG.
The IG is attached to the department.
But they are independent
In their investigative capability and their freedom to look at anything in the department, absolutely.
So then how can you deny them giving them what they request?
The statute's very clear on protecting the identities of whistleblowers.
But don't you
the
think
IG
that there's
had
a way
requested
that you can do that and also respond to the requests of an OIG, which has a very important function, one that the VA has not been able to do on their own?
Again, the IG requested unfettered access to a system that had Privacy Act information. If they want those documents, those records, they can be provided those. They just have to provide a written request. No reason for the request, which was part of the rub here. All they need to say is, we request these things. That provides coverage for that, for this office, for the records that they hold, to provide them. That's all they have to provide.
So it was a technical objection that you were making to what they did?
Well, it came born more out of, we wanted to cooperate with the IG and provide them access to this directly, working with us, but not unfettered access to where they just come in and out of that system for non-investigatory reasons. So we were trying to work on a way to do that. That's not something that worked out initially. So now we're just back to what the statute says, is just provide the request and the documents are provided.
So much
and we provided documents all through this period of time. So it's not like they've been refused things. We provide disclosures to them on a daily basis as soon as they come in.
So much of how much faith the public has in their governmental institutions is the level of transparency, and very often the facts don't carry the day. It is the perception of whether there is real transparency, real accountability. So when you act in the way that you do, I'm sure, coming from where you did, from the accountability and the whistleblower, you have to be aware that that visual, that perception is not a good one. And it actually seems to kind of track a disturbing trend in this administration in different agencies and positions as well, that they are the king and they control everything, and all these agencies just are meant to serve the president. That is not the way the government works. So when you take a position like you do, that's the perception that you leave, and I would hope that someone with your level of experience would understand that and try not to make that mistake again. I think my time is up. Thank you. Thank you, Mr. Chairman. I yield back.
Thank you, gentlelady, for yielding. Ms. Radewagen, recognized for 5 minutes.
Talofa Chairman Rowe and Ranking Member Walz. Thank you for holding this important hearing today. I also want to welcome the panel. Thank you so much for your service to our nation. Following up on a colleague's earlier question, Admiral Bono, as VA's EHR modernization program staffs up, do you believe it would be useful to have staff from it working on MHS Genesis?
Yes, ma'am. I think that's one of the reasons why we've continued, why we started to do our collaboration very early on, as the VA was even in the early stages of getting the Cerner product. Very much want to be able to leverage off of any lessons learned that the VA has, as well as be able to share what we're learning on the DoD side with the VA.
Can you elaborate on how this cross-pollination can be helpful?
Yes, ma'am. So a really good example is in the change management and the involvement of the clinicians. We have a fair amount of experience now with the change management and the workflow adoption, and that's something that we want to be able to make sure and share with the VA. Because this is a single instance of a medical record, that is, it's the same medical record, we recognize that being able to assist in the adoption of workflows that are common across DoD and VA will enable a faster deployment for us both.
Thank you, Mr. Chairman. I yield back.
Thank you, gentlelady, for yielding. Mr. O'Rourke, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I want to begin by thanking you and the ranking member for taking this committee's oversight and accountability responsibilities seriously. Glad that you're standing up a new subcommittee to track this contract, which I think all costs in may total $16 billion that we know of now. And I'm just grateful on behalf of our constituents, the veterans in El Paso, and making sure that we see this through and that there's the oversight and accountability necessary that's been missing in the past. I wanted to ask the acting secretary what paused the April 30th DOD report from the Director of Operational Test and Evaluation gave you in moving forward with Cerner One of the bottom lines in that report was a recommendation to freeze EHR rollout indefinitely. There are 156 reports of critical deficiencies. There was the suggestion that this Cerner platform may not be scalable. As they added new medical centers onto the system, those that had already been added slowed down significantly. It took pharmacists 2 to 3 times as long to fill a prescription as it would have had they not been using the Cerner system. There were reports that clinicians literally quit because they were terrified that they might hurt or even kill one of their patients. The user score out of a possible 100 was 37, and there are open questions about the accuracy of the information that's exchanged there. So what did that do to your and the VA's decision on adopting Cerner as a platform going forward?
I think as we discussed earlier, we've been working hand in hand with DOD and knew of some of the implementation issues that were described in the report and how they'd been resolved. We've integrated everything that we've learned from them into both our negotiating strategy and into product and then into our deployment strategy.
Yeah, so what pause did that give you? When you saw this, did you say, holy smokes, there's some significant problems here. We're going to put all of our eggs in this one basket, every DOD, every VA, health record, every active duty service member, every veteran, every military retiree. Did it give you any pause, or did you say, hey, it looks like they've corrected all these problems, and even though that report was a little more than 2 months ago, everything's fine?
We've never approached this project as just some sort of rose-colored glasses. We know this is going to be an extreme challenge for the VA and DOD, especially on the collaboration.
Let me ask it this way. What existing concerns do you have? So you saw the report. You believe that DOD/Cerner are addressing the issues. Do you have any outstanding concerns, anything that gives you pause, keeps you up at night?
So I'm going to turn it to John, but it's cost, schedule, and performance.
Because you said the buck stops with you, so I'd love to hear what.
Absolutely, it's cost, schedule, and performance. It's our ability to track to the milestones that we've developed.
Anything in that report that you do not think has been addressed or resolved?
There are items in that report we will resolve and continue to work on throughout the lifetime of this program.
Any fundamental issue like the scalability of it, like the accuracy of information, like the fact that clinicians have quit out of fear that their patients' lives may be endangered, any of that unresolved to your satisfaction at this point?
We're continuing to work with DOD to watch how they're resolving the things that have come up in that report and making sure that we learn those lessons.
The question that the chairman asked about how information would be accessed going forward once this is fully online, and the response about the joint legacy viewer being embedded and the ability to see information through that. If this is ever fully working, for service members who are going to be transitioning out over the next 10 years, there will be no legacy viewer for their information. It will seamlessly transfer from DOD to VA to third-party provider. Is that correct?
That is the intent of the program.
For all three, including the third-party provider. Whose information will still be viewed in the legacy viewer 10 years from now, once this is fully implemented according to the proposed schedule and budget in here?
Our intent is that everyone departing DOD coming to VA has a seamless transition, and then they're able to use all the VA capability that we have.
Those veterans whose records appear in the Joint Legacy Viewer today, will they be in the Joint Legacy Viewer going forward, or will there be some fix to that?
That is the intent.
Okay, to still be in the Joint Legacy Viewer.
No, to be in our
fully
system,
dumped out
fully integrated.
and the data fully integrated.
Yes.
Okay, Mr. Chairman, I yield back.
Thank you, Mr. O'Rourke. Mr. Bilirakis, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Secretary O'Rourke, it seems to me that electronic health record modernization is as much a process restructuring and standardization program as it is an IT program. Would you agree with that?
Yes.
Okay. Admiral Bono, same question.
Yes, sir. Fully agree with that.
Okay. How much of MHS, Genesis, has so far been a process redesigning exercise as opposed to an IT exercise, meaning writing code and installing hardware?
We're fully aware of the depth of change this is going to bring to our healthcare delivery system, and we're on the front end of working on restructuring those workflows and looking at what we have to change across our system.
Thank you. Admiral Bono, which aspects what has been the most challenging part of it?
Yes, sir. I think that the two most challenging parts, and I'm gratified to see that the VA is working on this up front, is governance and change management. Certainly the ability to make the decisions that are needed at the enterprise level to maintain that interoperability and that connection with the DoD effort is extremely important. And I think that what the VA is doing to help make sure that that governance structure and framework is in place is extremely important. The second piece that's extremely important is the change management, and as members and others here at the table have already identified, being able to involve the clinician right from the start is a very important part of that change management effort. And again, I see that what we've learned in our own efforts of deployment and the VA's initial steps to address that are very much in keeping with what we've learned.
Thank you. Secretary O'Rourke, how much of the process redesign is Cerner involved in, and how much is purely VA responsibility?
When it comes to this project, Cerner will be working with us directly to make sure that the process as we redesign them will work in their platform.
Very good. Admiral Bono, the MHS Genesis contract was awarded in 2015, and your testimony indicates its implementation will finish in 4 more years. That's a total of 8 years. VA schedule is 10 years. Are you confident you will be able to finish on schedule? I know that's so important. If you are confident in that, how is the military health system, which spans the whole country, as well as overseas bases, able to do this relatively more quickly than the VA?
Yes, sir. So we'll be doing that. I feel very confident that we'll be able to stay within our timeline that we've projected. Part of our deployment schedule provides that we'll be able to do many of this in parallel as we've been able to apply some of our lessons learned. So there's a lot of synchronization and amplification that we'll be able to do as we've put in place not only the lessons learned from our own personal experience, but also from the lessons learned that we're getting from those that are reviewing our progress.
Okay, final question for Admiral Bono. You've already bought your version of the Cerner EHR and implemented it in your first sites. How do you decide to select some Cerner software packages and not others?
Yes, sir. That was part of our requirements process in which we put together those functions and capabilities that we felt that we most needed to be able to replace our legacy systems.
Okay, very good. I'll yield back, Mr. Chairman. Appreciate
Thank you, gentlemen, for yielding. Mr. Lamb, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I want to follow up first on a question by my colleague, Mr. O'Rourke, about integrating what you learned from the DoD failures into the rollout of the new system. And whoever is best to answer this, please answer it. But some of the specific problems that they saw in the DoD rollout were, for example, prescription requests coming out wrong and referrals not going through to specialists. So just take those 2 specific issues, if you can tell us what you learned from the DoD rollout and how this program is being changed to prevent something simple like that from happening.
Absolutely. I'm going to let Dr. Sweeney answer that.
Yes, absolutely. So one of the big lessons learned that we had was that, again, frontline providers have to be involved not only in designing the process, but also in the testing process. I cannot emphasize that enough for myself every day, as well as the people that are involved on the team. Our users will be integral component of the user testing process to ensure that all of this works before we go live, that patient safety is accounted for, that we check off all of the boxes to ensure safety is maintained and the process works, if not as well as, but better than the way it works today.
Okay, so how will you ensure that a prescription is always going to come out correctly? Do you do like a drill or rehearsal or something with fake patients basically and your users on the other end to make sure that it works? Or explain to me how that is going to happen.
Absolutely. So the process of testing is where this happens. We not only test the technology to ensure that all of the technology behind the scenes works so that the prescriptions are going where it needs to go, but also that the correct prescriptions for the right patients are going to the right place at the right time. So that not only involves the technical component, but also the users, like I said, on the front end to ensure that all of those boxes are checked. Only when you have all of those things checked off that says, the process is working appropriately and that patient safety is maintained, can you go live in that process, and we have that accounted for in our testing process.
Okay, is that a different testing process than what the DoD used before they rolled this out the first time?
I'm going to defer to Dr.
We tested it through many instances of the different MTFs that we had in the Pacific Northwest. What we actually found, though, was one of the challenges for us is that we had different staffing models up there, and we had not accounted for that in the program. We have since addressed that.
Okay, so it will be a different testing and rehearsal process this time than last time, is my question.
Yes, we've incorporated that.
Now, Mr. O'Rourke, question for you about the VA budget. We just passed and the President signed into law the VA Mission Act, which basically changes the funding for the Veterans Choice Program from mandatory to discretionary funding and creates an issue next year for the budget cap on the overall VA budget, because there's this new funding that has now become discretionary and will count against the VA budget. Are you aware of the issues that that could create for your overall budget?
Yeah, we are aware.
Okay. Are you concerned about the VA's ability to implement this project with the electronic health records, given the constraints that are now going to be on your budget?
I believe the Congress has made it very clear on their intent on this project, so we have less concern about the execution side.
Okay. Do you agree that although the contract is for $10 billion, there could be an additional $5 or $6 billion needed for infrastructure and project management?
We're aware of that.
Okay. Do you agree that that is not really accounted for in the current budget planning, especially with this new money from VA Choice going into discretionary funding?
I believe we've been very transparent with the requirements of this contract, both from the contract
and I'm not saying, I'm not asking about the transparency. All I'm asking about is, do you believe that the money that you need, the additional $5 or $6 billion, is threatened by this change in overall funding that's going to push you up against the budget cap?
No, I don't.
So you feel fully confident that despite that change in the Mission Act, that you will have the money you need to implement this project?
Yes.
Okay, Mr. Chairman, I yield back. Thank you.
Thank you, Mr. Lamb. Mr. Pollock, when you're recognized.
Thank you, Mr. Chairman, very much. Mr. O'Rourke, thank you very much for being here, and all of you for being here. I understand you're a graduate from the University of Tennessee, a great chairman, also represents a terrific part of the state of Tennessee. I am assuming that neither one of you have been colluded about anything, and you'll be treated as directly as everybody else is on this committee. Going forward, let's take a look at this, Mr. O'Rourke, if you don't mind, since you're now the fellow sitting in the head seat over here. The reason why we're here today is because over a very long period of time, we've had over 100 different medical facilities that the VA is involved with, or owns, or runs, or whatever you want to call it. And they have, over time, created their own legacy systems, their own IT systems. Now, I'm a very direct person, and we love our veterans in the state of Maine that I represent. We have the first VA facility in the country, Togus, up in Augusta. However, I have never seen a part of our federal government, to be very honest with you, Mr. O'Rourke, who tries to be less accountable than the VA. 385,000 employees. You get folks that, not you folks, of course, but folks that come before us, and no one wants to take account. You look at the Denver Medical Facility that is $1 billion over budget. No one takes responsibility for it. So I've had it up to here when it comes to a lot of these issues. So you look like a reasonable fellow. I just want to make sure that I'm understanding that what we've had in the past when it comes to folks at the VA developing their own IT systems to build their own bureaucracies to protect their jobs is not going to be a problem going forward. Give me confidence.
Sir, that is one of the most straightforward concerns that I've had when I've looked at our IT office. In fact, that's the thrust of the work that we're doing right now, since the previous executive in charge left, was to go in and look and find where all those instances are, remove the waste of our spending, and find each and every opportunity we have to reinvest.
Let's stop right there, Mr. O'Rourke, if you don't mind. My colleague, Mr. Lamb, mentioned just a moment ago that it's a $10 billion contract. My understanding is a $15 billion contract over 5 years. What is it?
It's a $10 billion contract to Cerner Corporation.
Okay.
The mention, what Congressman Lamb was referring to is other infrastructure and personnel costs outside of
Okay.
what we'll pay.
Thank you for clarifying that. Thank you, Mr. Lamb. I want to make sure, so I'm looking at the right person. So when you come before us in the future, if it is you, sir, you are the person responsible for getting this done. Is that correct?
Absolutely.
Okay, good. There was another, I think it was Dr. Bono, Admiral Bono, excuse me, a moment ago, explaining that there need to be deep cultural changes. What the heck does that mean to you, because you're the head guy? What does that mean?
It means that exactly what you described when we have different hospitals creating different instances of IT systems, different groups that feel that they're not accountable to each other, to their veterans, to their leadership. Something that we addressed early on with the Office of Accountability and Whistleblower Protection of finding misconduct. Sir, I can just tell you that the process under work right now in VA is to become more accountable to you. We've done unprecedented ways of becoming more transparent, providing data, whether it's online or...
And you know, Mr. O'Rourke, you have the ability to terminate people who are ill-performing, correct, or underperforming?
I've exercised that
Yeah, okay,
authority.
good. We've given you that authority. The President signed that. You can do that. Okay, good. I'm guessing that somewhere in your office you have a whiteboard or you keep it on an IT system or a computer or some darn thing where you have a timeline, what you're going to get done, what the deliverables are, and how to measure that performance. Do you have that?
I have a 10 by 8 whiteboard in my previous office. They wouldn't let me bring that into the Secretary's office, but I frequently go back there to sketch out those timelines.
Great, wonderful. And is your vendor, Cerner, is that entity paid upfront to deliver product, or does the deliverable have to occur and you sign off on it before they're compensated?
With the firm fixed price IDIQ contract, we have that flexibility. That's what we discussed earlier, to make sure we can hold the contractor accountable, and if they aren't, then we can cancel task orders or delay other task orders if we're looking at a performance issue.
Okay, and that's a fixed-base contract over 10 years. You know, it's hard to project as a business owner anything 2 years out, but 10 years out is a long period of time. What confidence level do you have you won't be coming before us asking for more money?
Our intent is to execute within the cost and schedule that we have today. To do that, we're making sure that our leadership's engaged. Personally, I'm engaged. We have our senior leadership team meeting monthly, and we have weekly updates to me on this project specifically.
Good luck to you, Mr. O'Rourke, and everybody. We're all behind you, but we're going to hold your feet to the fire.
Thank you.
Thank you, Mr. Chairman.
Thank you, Mr. Poliquin, for finishing 4 seconds earlier. That's a first. I would now recognize General Bergman for 5 minutes.
Thank you, Mr. Chairman. And, you know, I feel, listening here for the last hour or so, I feel compelled to say, and I know we're all on the same sheet of music here, but why we're here. We're here to provide quality results for our veterans over the long term. It's no more complicated than that, but we can make life complicated if we allow the way we do things to get in the way. We talk seamless, but historically, bureaucracies walk a rice bowl, silo mentality of self-preservation. We know that. Only through proactive leadership that establishes a culture of civil collaboration across all boundaries will we even begin to have a chance of success in the change management that you talk about. People throughout VA at all levels must feel empowered to be part of solutions focused on results for veterans. I mean, that's pure and simple. It's as quickly and short as a Marine can state it. So, having said that, Mr. O'Rourke, the Appropriations Act stipulates that the EHR modernization program be controlled and administered by the Office of the Deputy Secretary. We've talked about the steering committee. We've talked about the governance. We've talked about the meetings. We also know that, you know, that position is vacant right now. So what's the plan here for the interim vacancy? Who's got the dot?
I do, and that'll stay with the Secretary until we have a Deputy Secretary appointed.
Okay, so you have the dot. How much of your daily time is it going to take to do this? Because we can only be one place at one time as an individual.
Weekly briefings to me from this team on the status, the milestones, progress, cost, schedule. Every visit that we make to facilities, whether it's a communications mission, if it's somebody that's not actively involved in the implementation at this point, and then with those places that are actively involved, taking an on-the-ground look and being able to come back and have a perspective.
Okay. Thank you. Admiral, you have a great deal of experience with operational and clinical standardization. The Defense Health Agency was created in part to unify military treatment facilities in the military departments. Please walk me through standardization in the military health system.
Yes, sir. So we've taken an approach with standardization that first encompasses some of our back office functions, that is, those functions that are common to all hospitals across Army, Air Force, and Navy. Those would be things like logistics, facilities, education and training, and in this case, health information technology. So being able to deploy the MHS Genesis has been a significant enabler for us to obtain standardization. And what that does then in standardization, if I could just use health information technology as an example, is using MHS Genesis, the Cerner product, as an enabler to help us drive towards more efficient workflows that put the patient right in the center and are responsive to their needs versus systems that have been responsive to the provider's needs.
Okay, so what you learned, from what you've learned so far, can you compare and contrast basically the military health system and the VA system? Are there specific crossover points or, in other cases, specific divides that there is no crossover?
Yes, sir. I believe that there are going to be some significant crossovers, and that's some of the things that we've already identified in many of our conversations as well as in some of our earlier collaboratives.
Okay. Thank you. And, you know, in an effort to beat Representative Poliquin, I yield back 50 seconds.
Thank the gentleman for yielding, and I want to thank the panel. I'm going to do a lightning round, and Mr. Lamb, one of the things that you brought up with the pharmacy is clinicians are going to want to make a medical visit, which is what VHA is all about, as seamless and as good as they can. They want to make it quality. They want to make it a pleasant experience. People are intimidated when they come in, and can be until they get familiar with the system. So that would be our objectives. And Dr. Bono knows this as an admiral in the Navy. We in the military, and there are 5 of us, so of us sitting up here, will salute and say, yes, ma'am, and make it work, no matter how awful it is. And you're going to want to make that. So when your wife goes in to get a prescription, all she may know is that, hey, it took me 5 minutes, I walked up and got it. There's a lot of people behind the curtain and make that happen. And what we don't want this system to do is make that harder for the people to do it. It will frustrate them and they will leave, I'm telling you. I say this as a joke, but in much way, it's not an electronic health record made me a congressman. So people will search out something that's easier. So we have to make this as user-friendly. I know Cerner is here and will be on the next panel. My one question in 1 minute, I'm going to yield everybody a minute if they want it, and I didn't get it answered. Maybe Cerner will do this, but, and Mr. Rourke, you may be able to answer this also. We're spending $1 billion a year to maintain the current legacy system. When that handoff occurs, will there be any savings, or will that system still cost $1 billion plus to maintain the Cerner system each year?
Theoretically, that would be the cost savings once we have a fully implemented Cerner solution. That's what we have to work toward. That has to be our intent.
Does it look like that can happen? I mean, in other words, we replace a piece of technology. Is it going to cost us just as much as what we had to maintain it? It's new. I mean, is there a contract afterwards? I know you're going to have to maintain this system.
I'm sure we'd have to maintain that system. Whether it'll cost the same as what we have today, I would suspect not.
Because the $10 billion and the extra $5, almost $6 billion, is for the rollout. But after 10 years, or whenever this thing is fully operational, you're going to have to pay. There's going to have to be a management contract after that, I'm sure. And my question is, how much is that money? How much money is that going to be?
We'll have to take that question back, sir, and come back to you, but we'll keep that in mind.
Yield, Mr. Waltz.
Just some yes or no, Mr. O'Rourke. Isn't it true the OIG has not received any information to date from the OAWP?
No, it's not correct.
That's not true?
we've provided them disclosures consistently.
True OIG has agreed to liaison by sending 2 staff members on May 2nd to review referrals, but were denied access due to lack of reciprocity.
They were requested by us to have a meeting to collaborate with, and then they requested that unbeknownst to us.
True that you conditioned access to the OAWP files contingent on OIG providing their files.
That's not exactly true. That was whistleblower disclosures to be shared under the statute.
And I will state for the record that confidentiality was never raised by the IG to this office of talking to us until this testimony today, which I remind everyone was under oath. With that, I yield back.
And gentleman yielding, Dr. Dunn.
Thank you, Mr. Chairman. I want to get a level of comfort, and this is probably Dr. Zanuz. I was reading through the memos and the briefs there, and I was seeing standardized workflow, and to me that meant standardizing the way the clinicians are using the EHR, the way we enter and retrieve information. But as I kept reading on, it sort of morphed into a best practices thing, and I want to be reassured that what we're not talking about, this is not code for clinical medical practice guidelines, treatment guidelines. Tell me it's not code for that.
So workflows are the way we do business, and our goal is to involve our frontline clinicians to ensure that the way we want to do business...
Treatment guidelines, you know what I mean, diagnosis-related treatment guidelines.
So the EHR system does allow for collaborating with DoD to input clinical practice guidelines and have that be part of the clinical decision support.
So that would be suggestions like the NCI guidelines, things like that.
That's correct.
I mean, this is not like, this is the way you will practice medicine.
That's correct.
You understand, as a physician, I'm sure,
That's correct.
my concern here.
Absolutely. So our goal is if the clinician is ordering something, for example, and has the option to have decision support available.
So my time is expired, but I do want to make sure that you understand that when we start doing top-down treatment guidelines, you will treat this diagnosis this way. We always get it wrong, reliably get it wrong. The government's proved that repeatedly.
Absolutely.
I yield back, Mr. Chairman.
We always get it wrong, correct. Mr. Takano, you're recognized.
Mr. O'Rourke, I want to follow up on my earlier questions. I understand that the Deputy Secretary, Undersecretary role, and the Deputy Chief Information Officer are the province of the VA, not the White House. It has come to my attention that prior to Dr. Shulkin leaving, that a committee, internal committee of VA, has reviewed potential undersecretary names and has already met 3 times and passed the name along. Can you comment on that?
It's for the Undersecretary for Health?
Yes.
Yeah, actually, we've had 3 commissions over the past year to evaluate names for that position.
And that they've passed a name along, is that correct?
They did pass candidates along to the White House, and I believe they weren't selected.
Well, Mr. Secretary, I'm just really concerned that there seems to be no urgency to fill these positions that are critical to overseeing a $15 billion project.
Sir, I can tell you that we're starting a new commission.
And this is on you, not the White House.
Okay.
Thank you.
Ms. Brownlee, you're recognized for 1 minute.
Thank you. I just wanted to get a clarification. I wanted to follow up on Congressman O'Rourke's question about the legacy data being built in seamlessly to the Cerner. And Mr. O'Rourke, you said that was the goal, that's the intention to do it. Then I heard from the Admiral that you, within the DoD system, that you have a portal, if you will, for the legacy data, which sounds to me like you push that button and you get the legacy data. And it's not necessarily integrated into the system. So is that true, Admiral, in terms of what the DoD is doing? And so you have a different objective than the VA?
Thank you, Mayor, for letting me clarify. No, we have the same objective. It's just that we are in transition, and while we are in transition, until we get onto the same single instance of the electronic health record, we have to use some kind of bridging product that allows us to maintain visibility of that. So that's the Joint Legacy Viewer. In DoD, we're also using that because in some instances, for our patients and our MTFs, not all of us have been deployed to MHS Genesis yet. So that's an interim support.
Thank you. I yield back.
Thank you, Mr. Poliquin. You're recognized for 1 minute.
Thank you, Mr. Chairman, very much. Mr. O'Rourke, are we on schedule and on budget with this contract?
Today, yes.
Okay, and when did you start the contract? When did you start the project?
May 17, 2017. We started negotiating the contract May 17th of 2017.
Okay.
We signed it last month.
Okay, but you've started. You're not waiting. There's no reason to wait. You're moving forward.
We're moving forward today. As you can see, we're putting together, organization plans and milestones as we speak.
What keeps you awake at night that can cause this thing to derail and you have to come back to us and say it's been a failure or you need more money? We don't want that, either one of those to happen. So what could cause that to happen?
A lack of focus on cost, schedule, performance. Anytime you let your eye get off that ball, you're going to run into problems.
And you're not going to let that happen?
No.
Thank you, sir. You're back my time. 10 seconds, Mr.
Yielding.
Chairman.
Mr. Lamb, you're recognized.
Thank you, Mr. Chairman. Question about the risk score when it comes to opioid abuse risk. I think that was you, Doctor, that talked about that. Can you just tell me who created that score and a little bit more about the criteria as much as you can in this short time frame?
Sure. I cannot remember the name of the company that Cerner uses, so I'll have to take that for the record. VA internally has its own risk scoring system. We will be evaluating to see what efficiencies we can take out of that system and incorporate it into the Cerner system. But what we've seen so far is that all of the PDMPs that participate, all of the states that participate in the PDMPs are available to the system to aggregate and create the risk score as, and the military health system, if they participate or if they share data when they share data with the VA, will be aggregated and incorporated into that scoring system.
Got it. If you wouldn't mind just following up and letting me know who it was that created that, I would appreciate it.
Absolutely.
Thank you, Mr. Chairman. Yield back.
Thank you, gentlemen, for yielding, and there are no further questions. So, Mr. Secretary and Dr. Bono, thank you for being here. It's been very helpful and very informative, and you are now excused. Thank you. On the second panel, we have again Mr. John Wyndham and Mr. John Short and Dr. Zinus, representing the VA. They are accompanied by Mr. Zane Burke, President of Cerner Corporation. And on the panel, we also have Dr. David Powner, Director of IT Management Issues for the Government Accountability Office. Yeah, I'm going to. I'll just swear it. Huh? That's it. For those of you all have not been sworn in, would you please rise and raise your right hand? Do you solemnly swear under the penalty of perjury that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Let the record reflect that the witnesses have answered in the affirmative. Mr. Powner, you're recognized for 5 minutes.
Chairman Rowe, Ranking Member Walls, and members of the committee, thank you for inviting GAO to testify on VA's EHR modernization and our ongoing work for this committee looking at VISTA. Our review is looking at both the cost to operate and maintain VISTA and exactly what VISTA is. Understanding the costs are important since VISTA will be around until the EHRM solution is fully deployed. Knowing the full scope is important to inform the planning of the EHR modernization. This morning I'll cover the costs of VISTA, what VISTA is, and provide suggestions as VA proceeds forward with the EHR modernization. VA currently spends about $1 billion a year to operate, maintain, and enhance VISTA. Major components of these costs include interoperability efforts, electronic health records, and infrastructure costs for hosting and storage. Tallying these costs is not an easy exercise since it entails contracts, internal labor, major programs, and components funded by both VHA and OI&T. These detailed costs over the past 3 fiscal years are provided in my written statement. Now turning to what VISTA is. Understanding the full scope of VISTA is essential to effectively planning for the new system. There is no single source that fully defines the scope of VISTA. However, VA has undertaken several analyses to better understand it. One that I would like to highlight is their application view of their health IT environment. There are over 330 applications that support healthcare delivery at a VA medical center. About 128 of these are identified as VISTA applications, and 119 have similar functionality to the Cerner solution. The bottom line here is that it is important to know how much of VISTA the Cerner solution will replace. Some analysis say around 90%. The application view suggests a much lower percentage. Mr. Chairman, we want to avoid a situation down the road where there are surprises as to exactly what the Cerner solution is replacing. This understanding of VISTA is further complicated by unknowns caused by individual facility customization that has occurred over the years. Now turning to the 10-year, $10 billion Cerner contract that was awarded last month. It is important to note, as mentioned prior, that the EHR program is expected to cost about $16 billion because VA estimates about $5.8 billion for project management support and infrastructure over the 10 years. Not included in the $16 billion are all internal government employee costs, so the 10-year price tag is even higher. I want to be clear here that going with DoD's solution is the right move, but given the complexity and costs and the fact that both VA healthcare and IT acquisitions and operations are both on GAO's high-risk list, this acquisition needs to be effectively managed. My written statement highlights several detailed practices that we have seen applied to successful IT acquisitions that are important to the EHR program going forward. But there are some big-ticket items that are critical to pulling this off. These are, number one, congressional oversight. We commend this committee for proactively establishing the Technology Modernization Subcommittee. Continuous oversight of the EHR program will make a difference in ensuring that it is executing according to plans and budgets. Number two, Executive Office of the President involvement. The White House involvement can elevate the importance and accountability here. The current administration has several EOP offices whose involvement can help. We also think that the federal CIO's involvement is important. Number three, governance and building a robust program office. Both interagency governance with DoD is planned, as is a governance process that reports to VA's Deputy Secretary. It is important that this governance structure has a strong CIO role and that it ensure better collaboration between VHA and the CIO shop than has historically occurred. Also, we have seen governance structures embed the contractor to create better transparency and teamwork. In addition, if a governance structure is robust and open to risk, we have also seen congressional and GAO staff welcome to attend these meetings. We believe this is a best practice and frankly save agencies time in responding to oversight questions. Number four, business change management. A major issue with federal agencies is adopting commercial products and their unwillingness to change their business processes. For the EHR initiative, this entails clinical workflows. This is definitely a high-risk area for VA. And finally, number five, building in appropriate cybersecurity measures and optimizing infrastructure. VA has cyber challenges that are important to this new EHR acquisition, including controls associated with network security and controls for monitoring systems hosted by contractors. Regarding infrastructure, these costs appear exceptionally high with the VISTA program, and VA needs to consider a more comprehensive data center optimization strategy that coincides with their new EHRM approach. Mr. Chairman, this concludes my statement. I look forward to your questions.
Thank you very much for your testimony. Burke, you recognize 5 minutes. Huh? Oh, we'll go to questions, okay. We'll go to questions, Bill tells me, so I will go to questions. First of all, I'd like to start, and I appreciate you all being here, and Mr. Burke, help me with some back-of-the-envelope math here. The EHR modernization is going to cost almost $16 billion over 10 years, $1.58 billion per year. According to the GAO, the cost to run VISTA is about $1 billion a year. And again, I asked this a minute ago, and the Secretary couldn't tell us, what does the cost to run the Cerner EHR look like after the 10-year implementation? And does the total cost of Cerner drop below the $1 billion a year? Is that just going to be the cost of keeping this up and running? Or does anybody know that answer yet?
Mr. Chairman, thank you for conducting this hearing and our participation in it. As it relates to that question, we do believe that the costs will be less than the ongoing costs of the current VISTA system. Several of those items that reflect some savings will be around the fact that today the VISTA instances are over 100 different instances. You have a number of different training people, the upgrades, the updates, those kinds of things are significantly more expensive in those models, so we do anticipate taxpayer savings over time.
Well, 10 years is a long time. I was at Oak Ridge National Labs a couple of weeks ago. They spent $200 million on a supercomputer in 1996. They told me that now your iPhone has as much computing power as that 200. So in 10 years, who knows how much the technology is going to, it's going to change dramatically. I can tell you from the rollout that DOD is doing right now in the Northwest and what VA is starting in October is going to look totally different in 2028. So I think there will be added cost, and there, I don't see how it couldn't be more cost. Dr. Zinus, one of the things that, and again, Dr. Dunn and I will continue to go back to this, is how important it is to make an EA. I hear this all the time, to make the clinician's job easier and more efficient instead of just polyboxia, just punching boxes and entering data. And, you know, that's what we feel like we are now. And I understand that in some respects in VISTA, believe it or not, people kind of like that system. They're used to it. So we're asking the clinicians and the people, 380,000 people, to make a gigantic change in the way they do their business right now. And is it designed around how people want to do things, not necessarily the most efficient way? And you have to configure the EHR from the ground up, not the top down. Dr. Dunn just mentioned that. And that starts by collecting input from really thousands of people, nurses and doctors and supply technicians and all that, scheduling people. All of those have ideas, and many of them good ideas. Are we doing that, or are we just turning that into a check the box, and we're going to go on and do exactly what Cerner has already laid out? Which is it going to be?
Thank you so much. In my role as the functional champion, change management obviously is at the number one priority for me. And I recognize as a clinician that burnout, because of checking boxes, as you say, is a key reason why people get frustrated with this process. So we have ensured from the very beginning that we have frontline folks involved in this process, in the requirements process, so not just the doctors and the nurses and the dentists, but also the medical support assistants, the schedulers, et cetera, supply chain folks sitting at the table with us to put in the requirements for this process. They will be integral in designing the workflows to ensure that it is both efficient and meets their needs. I mean, we have to look forward to make sure that we're not just doing things current state, because we understand in VA that there are efficiencies to be gained, but at the same time, we will make sure that we take in best practices and work with our frontline folks to design a system that works for VA.
Yeah, what we're doing is we're making data entry people out of our clinicians, and we're doing, I think, a pilot program now on scribes, just to help let the doctors, nurses be doctors and nurses. And I know several years ago, when my wife was critically ill in the hospital, and I got to sit there and watch the system, not as a physician going around making rounds, but as a patient. I saw the clinicians and the nurses spend more time entering data than actually at the bedside. That's not good. That's where technology has not helped us. It has not made quality better. It has not done any of that. So I would strongly encourage you to make sure that you include all of these people that are going to be using it. And then the other thing I think was said by Admiral Bono was that you have to train people on what you're going to use. I don't think DOD actually did that to start with. And you've got to have them well trained, because it's going to be a very anxiety-producing problem when we roll this out. The next 18 months, if I'm in the Northeast, if I'm in Washington State and I'm at a VA, I might want to transfer to Mountain Home. So I now yield to Mr. Walls.
And thank you all for being here. Mr. Powner, you talked about the governance board. It sounds like you're pretty confident they're standing that up in your. My request is that you be involved, as you say you are, and that you be involved in those quarterly progress reports. Do you feel at this point in time that's on track, and you feel comfortable being part of that team?
Yeah, we feel that that's important. We have experience doing this with other modernization efforts, too. When you look at some of the things that have gone on, like at IRS and other agencies, we've been embedded in some of those governance processes. And again, if you're confident in your governance process, and I've talked to Mr. Wyndham about this, he's confident, and I think he welcomes us there. I think it saves time for everyone.
Yeah, this is really encouraging, and I think that's where you saw the line of questioning. There's always another partner at the desk with us on this, because oftentimes you ask us to implement the IG findings, the IG that does that. It's obvious that the IG is not a welcome partner at this point in time. There's open hostility. There's no secret to anyone here, and that's the point we're trying to get to. In your experience, how important is it for those IG eyes in these types of projects and implementation?
Well, I think both GAO and IGs need to have access to the right information and timely. I will say from GAO's perspective, we get access. Historically, it's been slow, okay? We get data, but it's slow. But I will say Mr. Short and Mr. Wyndham, they've been more responsive than others in the past, but it needs to be timely. We don't have time to be slow here. And the bottom line is, you got it or not, don't create it. If you're creating it, you're not managing it.
Yeah, this is a new dynamic, though. It's not just the slowness or whatever. There's a reinterpretation of what we have to do and what we don't have to do. There's a whole new dynamic at play here with the Secretary basically saying, I'm in charge of you, and I will tell you when you investigate. That's what's different here. And at the start of a project like this, I cannot stress enough that I think that is your fatal flaw. If this is not fixed, addressed, and cleared up immediately, because so many things have come out of that IG. So I appreciate you being there. Mr. Burke, congratulations. You got a $10 billion contract, and now you got a whole bunch of partners. So we're here to ask how you interface on this. How do you see the role of this new subcommittee that's set up with the responsibility to the veteran and the taxpayer, and you with every right as a private entity that is providing a contract and a service to improve veterans' health care, to do what's needed for our warriors, but rightfully so, you have a financial stake, as you should, to make this work. How do you view what we're setting up here and how that interaction would work, and how you would view our request for information in the appropriate way to find out where we're at?
We view it as part of an appropriate governance model. So we're very excited actually about this subcommittee and think that it's a great approach. Our obligation is to serve the veterans at the end of the day, and that we want to bring seamless care, help the clinicians who serve those veterans, and have them have the most effective means possible to do that. And so we view that very positively.
No, I really appreciate that. And I know your team, this was months ago, way before this was going, when I wanted to come up to speed on different systems, and you sent really good people out who sat down with a layman to look at how this would work with myself. Dr. Rowe knows a lot more about this, understand this. I represent the area of southern Minnesota where the Mayo Clinic is, so I'm familiar with their electronic record, their switch to Epic, and looking at all of that. So I said from the very beginning, though, I really want to make note of your team was very open. They were there. They were talking about things that worked and didn't work. They were projecting ahead of potential problems that may arise, and I think that openness, that transparency, that seeing us as partners and different eyes on this to the same goal is really healthy. So I'm grateful for that, and I yield back.
Thank you.
Thank you, gentlemen, for yielding. Dr. Dunn, you're recognized.
Thank you, Mr. Chairman. Mr. Burke, welcome to our panel. I look forward to working with you. I'm the chairman of VA Health Subcommittee, so I think we'll be seeing a lot of each other over the next few years. I want to address a question of workflow councils right now that are doing the mapping and this workflow standardization. What is Cerner's interaction with them at this point?
We're just beginning that process, so the teams are coming together. The plan is basically we will work with the VA, and we'll also bring other third-party industry partners that are industry experts in that space, and the VA will supply the leading folks on their side to be part of those councils as we move forward.
Okay, so you have an immense amount of experience with the EHRs. I do too. I'm one of your clients. I want to know how you're making, to Dr. Rowe's point, how are we going to make this a not frustrating, a productive interface for all of the clinicians, doctors, nurses, everybody? How do you do that? Because I can tell you there's a lot of frustration. Just as a point, 2 weeks ago there was an article came out and said that the average physician in America spends 53 hours a year just logging on to his EHR. 53 hours a year logging on. Make me feel better.
Well, first off here, and it's an appropriate question to ask, and it is the process by which we'll go forward and come up with best practice. We'll bring the best practice. The buy-in from the clinicians is incredibly important. We're doing current state analysis. So what do the clinicians have today? And then do a crosswalk, what will it look like in the future? So that you set expectations. We understand if they already have certain capabilities, will they get enhanced capabilities? Are there elements where we'll be challenged? We try to understand those kinds of things up front so that we can do that work along with those best practice elements. The other side that I'd look at is, as a company, our number one priority is the clinician experience. And unfortunately, EHRs have become really box-ticking exercises for the clinicians. And it's reduced the time with the patients overall. And our obligation as an industry is to come forward with other technologies which make it where the clinicians can actually spend more time with the patients. It can be much more natural in the workflow and those kinds of things. And over time, what the VA has done has really contracted for those upgrades to be part of the solution set. So as you think about the go forward space, absolutely the EHR of today will be different from the EHR in the future. The VA is contracted for those upgrades. That's part of the process.
Do you currently have biometric logons?
That is part of the capabilities.
So that can, if it works, you can make that a lot faster.
Correct.
Of the $10 billion contract, how much is hardware and how much is software?
I'm sorry, sir. I'd have to get back to you on exactly that.
Sir, does it include hardware?
Sir, we've acquired software and related services from Cerner Corporation, so things like maintenance, software updates,
I'm asking, do the laptops and things, are they included?
That's part of our infrastructure buy. Cerner is not buying those.
So outside the $10 billion, there's a whole lot of computers to be bought.
Well, that's why the $16 billion number,
okay,
$10
so
billion is allocated to Cerner for the Cerner contract.
Okay.
$4.59 billion for infrastructure upgrades that would include that type of hardware, okay, and then $1.2 billion for program management oversight.
Just trying to get a sense of where that was located. That's very good. So I'm getting short on time, but I do want to leave Mr. Burke. We're happy to work with your people. We're going to be working with them. We want to work with them up front. We want to make sure that you've got a system that's palatable to the people who are actually using it. And I know you know in your business that that's really not a very common thing. We all have a love-hate relationship with our EHRs. I have spent literally millions of dollars on EHRs, and I was kind of hoping I wouldn't have to do that when I got to Congress. But now I went from millions to billions. Mr. Chairman, I yield back.
I was going to say you're spending billions now, not millions. So, Mr. Takano, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Powner, you in the opening testimony said something about the percentage of VISTA that need to be replaced or addressed varied. Could you expound on that a little more, because I want to understand what you're saying?
Yeah, so there's a couple different views when you look at what VISTA is. You can define it in what's called modules, and the module view says that the Cerner solution will replace about 90% of what VISTA is. But if you take an application view, it's much less. So that's why it's a little confusing. I don't have an exact number for you, and I do think VA has attempted to look at this. But again, I think what is very clear here is similar to how Mr. Wyndham just answered this question. What's in the Cerner contract and what isn't? And then what's in the 5.8? You don't want surprises that you got $10 billion here and 5.8 here to cover infrastructure and program management, and you find out there's another $2 billion outside of that to implement the solution. That's still a little fuzzy in our mind. We have a report that we're currently working on for this committee that we'll be hoping to provide some more clarity on that.
Do you believe you, within GAO, have the requisite expertise, the numbers of experts to be able to perform this analysis?
That analysis, no, we're not performing, well, we're relying on VA's analysis on the specific applications and modules, but I got experts that could say whether that analysis that VA is conducting is appropriate or not, yes.
And do they believe that VA has the resources, the personnel?
Yeah, they got the resources and the personnel. The problem is they got a lot of unknowns because of the customization. I mean, I think it's very unclear the best way to characterize it. There are all these unknowns, and how much of those, you don't know what you don't know. And when these specific site reviews that are currently ongoing are going to shed a lot more light on that.
So there's kind of a scan of all the different sites and what individual customizations occur on those sites.
Yeah, exactly.
You said it could be up to 90%. What's the other view? How much?
Well, the other view is like in the 50% range, but again, we think that application view entails a little more than Vista, so it's hard to compare the two. But I will get back to this question about long-term, post 10 years, about the O&M costs. I sure hope that it's a hell of a lot less than the $1 billion that we currently spend. We got standardization, we won't have an old language, and we can save a lot of money in the hosting arena. I can tell you the data center optimization initiative that the whole federal government undertook, VA is one of the worst agencies on consolidating and optimizing their data centers. This is an opportunity to do that right with this Cerner implementation.
And so, on balance, you believe, you stand by the decision to go with, as you said, the DoD solution, right? I mean, there were people who were advocating.
No, we advocate go with a common solution and go with the commercial product. We've advocated that all along because you got to get there eventually. Or Vista, it's just long term. It's going to be more and more to maintain.
Mr. Burke, I know that the emphasis. My colleagues were all excited about the potential of integrating to an interoperable degree these systems, the VA system with the DoD system. I'm also concerned about the interoperability with the non-VA providers because that's a significant part of what we do. And specifically, I'm concerned about the idea of portability of data, patient data, and I believe that data belongs to the patient. But I don't believe that that's how even the private sector operates, that we have proprietary behavior among the other EHRs out there. Is this an opportunity for the VA to be a leader in this case? And I'll just stop and let you comment on what I've raised here.
Appreciate the question. It is absolutely a space where the VA can be, we believe, will lead the country on this side, and both the DoD will help in that perspective. I have a personal belief that's the same as yours, is that the personal health record ought to be mine, ought to be yours. As part of that, we'll actually be offering personal health record for free in terms of any one of our clients in that space, and we announced that probably 9 months ago in that realm. We participate in all the HIEs and all the connections. We also believe that other technologies will be written that will need to go on top of our platform, and so making our platform more open in that perspective is also important. So interoperability, openness is part of the foundational elements of the contract and really what we anticipate doing both with the DoD and the VA.
Mr. Chairman, I look forward to this new subcommittee you're setting forward because I think we can help the American people understand what's at stake here in terms of this potential greater portability and the VA's ability to leverage its position with regard to the other EHR systems that are out there. I yield back.
Thank you for yielding. Mr. Penner, I hope you're right, but in my experience in the private world was that I always spent more and more on technology, not less. Mr. Banks, you recognized.
Thank you, Mr. Chairman. Mr. Wyndham, how did you select the Spokane, Seattle, and American Lakes as your initial implementation sites? And was this because the Defense Health Agency had already selected nearby sites, or did VA reach this conclusion independently?
We had an ongoing negotiation with Cerner Corporation as part of our contract award actions that took place this past May. And so as we sit down and we negotiate parameters that are going to be cost drivers and variables within the framework of that negotiation, economies of scale associated with labor were one. DoD was in that region. Negotiating on behalf of the taxpayers and our veterans, I'm always conscious of what we're going to pay, especially and still with an eye on not compromising the care to our veterans. So economies of scale of labor were introduced by Cerner Corporation in going to the Pacific Northwest. In addition, that foundational issue, interoperability. If we're in the region with DoD, that is a quick way to test whether our interoperability strategies work. And so being in that same region, to me, demonstrated one of the major premises of the DNF, the determination and findings, that were at the forefront of our efforts, which was interoperability. And so we look forward to demonstrating that in the Pacific Northwest once we deploy there. But that is part of the terms and conditions that we agreed to, and with a focus on economies of scale with labor and also interoperability objectives, sir.
Have you been to each of the initial implementation sites?
Sir, I had the fortunate opportunity to lead the DoD effort. I was the program manager overseeing that while I was still on active duty in the Navy. And so I am now on the VA side. So to answer your question is I have been to those sites.
But not since they were selected as the initial implementation sites.
Not since they've been selected. Not since I've been working with the VA. I have not been to those sites.
What about our other VA guests? Have you been to all three?
Short has been there.
Mr. Short?
I was at the Fairchild Go Live when DoD went live there.
And Doctor?
I have been to other sites in that area, but not the particular site. I've worked in several VAs.
You have not been to the initial implementation sites?
Not to the initial sites. I have visited Seattle in a capacity, the Seattle VAMC, but not in this capacity.
Okay, so I just want to clarify, Mr. Short, you have been to the initial implementation sites since they've been the initial implementation sites?
The DoD sites, when they went live.
DoD sites.
We went through them as they brought in new patients and processed them and went through their training facilities, their war room, went through all that.
Okay.
I just want to make sure I'm clear. We just characterize our visits to the DoD sites.
I understand.
Our initial operating capability sites, we have visited as part of our pre-screening efforts associated with establishing them as the sites to be deployed to.
I apologize. I'm easily confused, I suppose. But do you believe that the IT and clinical departments at these medical centers are sufficiently strong, or will the VA be making additional investments in them to prepare the implementation?
Sure, they deliver high-quality care today. I can't emphasize the change management strategy that we're about to subject them to and how difficult that is. So I'm going to defer to the clinician because she's got the pulse of the people on the ground, and she can give you more of a characterization.
Doctor?
Thank you. So we have been working with the VISN director in that area since the sites were selected, and we have been working with them to ensure that that they will have the staff that's required. We have identified change management leaders on the ground, executives, as well as informaticists that will be participating in this project. Several of the folks are involved on my team directly and have received the appropriate change management training. If we go to the when we go to the site review and identify any gaps, we intend to address that immediately so that by the time of go live, which is 18 months from October 1, they will be ready for what's coming.
Are there any, Doctor, are there any discussions at all occurring about changing the implementation sites, to your knowledge?
I think we're always evaluating what's best. We've had several discussions to see if we should be looking at other sites, but we've always been talking about it from day one to ensure that we're going to the right place. As we evaluate leadership, informatics leadership, IT leadership,
So
executive
yes
leadership.
Yes or no, are there conversations about changing the implementation sites?
We've had these conversations since day one, so yes, we're continually evaluating, absolutely.
Okay, my time has expired.
Thank you. Ms. Brownlee, you're recognized.
Thank you, Mr. Chairman. Mr. Burke, I wanted to ask you, this might be an elementary question, but it relates to the interoperability issue and the concern about being compatible in the community. It seems to me that Cerner, Epic, nobody has been able to achieve interoperability so far, so it seems to me that I get that we'll be able to communicate with DoD, being the same system, but to be able to go out and communicate with the other systems out in the universe seems to me like we're going to have to create new software, a new system that has not been identified yet to be able to do that. Is that so? We're going to have to invent somehow to make that possible.
It's a great question. Historically speaking, there were a lack of standards as it related to data flowing between systems. And so there were some technical elements between different systems, and there's, interestingly, almost 200 different EHRs out there between the ambulatory side and the acute side. And beyond just the ambulatory and acute, there's the full continuum of care that ultimately we need to connect. There's been quite an evolution of those standards, which has been very helpful. And part of that has been part of our conversations as we paused in the contracting process, was to go through that evolution and codify that in the contract to say what is possible today, and then what's the art of the future tomorrow. And so there are parts of those elements which are, let's go implement the things that we can go do today, and then there are other elements in there that we're contractually obligated to, on a go-forward basis for enhanced interoperability as we move forward. So I would look at it and say that technically speaking, there isn't a challenge on as big a challenge on interoperability today as there once was from a technical perspective. There are still business processes within the communities that create a different experience on the availability of that information. One of those is who actually does own the personal health record itself. And so that's one of the reasons why we're offering a personal health record for free for any of our clients, anybody that wants to do that, because we think that's ultimately one of the ways we move past some of those business model challenges in that space. So it's a very complex arena. I can assure you that we have spent a significant amount of time on that. We're committed to this process, and we actually do think it's an opportunity for the VA and the DoD to lead in this space, and I'm convinced that we have the capabilities to go forward and do that. And the VA also has the funding mechanisms by which to really enhance the community to want to participate in that process as well.
So to sort of break those barriers, if you will, is it going to require the cooperation of the other electronic health records out there to be able to get to the ultimate, as you said, the art of the future? Is it going to, is that the requirement, or is it, you know, some really IT person back in a room creating a system that is going to, you know, encompass all these other systems out there to make it compatible?
Today, there's an organization called Commonwealth, which is a not-for-profit interoperability group that actually is committed to standards, which has over 50-plus different members from the EHR community that have agreed to code their solutions to a certain spec. And so that's been an industry-led element. We were one of the founding members of that organization. In addition to that, that group, Commonwealth, is what's called a care quality implementer. So it's a second group that really has a set of standards which connects my major competitor in, as they are not part of the Commonwealth standard, but they are care quality standard. And so Commonwealth will do the implementation. So it should connect all those pieces there. It will. But
if they don't succeed, we don't succeed.
That's part of the dynamic of the interoperability side. The pressure side coming from the providers and their clients will be quite significant in that. And I'm in a spot where I think I should defer to Ash and let her communicate as some of the sticks that the VA has for compelling some of that in the community care.
Just to
let
you know, one of the big mistakes we made in electronic health record was that we didn't make them where there's a same platform. Look, everybody, whether it's Cerner or Epic or Allscripts or whomever, they all silo their information, but information is money. And and I do understand. Yeah, and it's incredibly important to be able to share this data. And I agree with you all, the person's health record is whomever the person's health record is. It's yours, Mark, or mine, or whomever's record. I totally agree. That's who owns it. Mr. Poliquin, you're recognized.
Thank you, Mr. Chairman. Doctor, use some of my time right now to go ahead and answer your question, or answer the question that Mr. Brook threw over to you.
Absolutely. Interoperability is not an end state. It requires constant care and maintenance, and it's not just you get to a certain data element or you share something and it's done, users are going to continually ask for more and more things to be shared for the providers to provide adequate care, and patients are going to want that data available to them. For that to be possible, I think there are a couple of different elements that you need to address. One is the technology. As technology advances, we need to ensure that VA keeps up, and it is our intent and part of our contract to keep up with that through innovation, through adoption, et cetera. Number two is policy and legislation, which is very important. I know that Congress had pushed forward on information blocking to ensure that that ends, that we share more information across the system. But obviously, that can be expanded, as you've said. And number three, I think the VA will participate in, engage directly with the Office of Community Care in the community care networks that we contract with to ensure that we get as much information as possible, not just limited to certain data elements, whether it's allergies or medications, et cetera, that we get as much information as we can and need to provide the adequate care that's necessary. So I think it's a three-pronged approach.
Thank you, Doctor, very much. Mr. Burke, congratulations for your company winning a $10 billion contract over a 10-year period of time. Your job, and you know this better than I do, is to deliver a project that works on budget and early. And I'm going to be one of the people on the committee that's going to hold you accountable and everybody else that's involved. That being said, I'd love to have you comment on this, sir, if you don't mind. I think you have two problems, one of which is convincing people that it's better for them to use this instead of a flip phone. That's one. That's a technology piece that I'm sure you folks can get to. And the second one is one I think it's more significant, and I'd love to hear your comment on this, is how do you convince the people at one of the, arguably the largest bureaucracy in the world, or one of them, to do something differently that might, at least they might have the perception is going to threaten their job? Because they've built these legacy systems throughout our country that are incredibly expensive. They don't talk to each other, so our veterans are being hurt. But now you're asking them to do something entirely different, not only using different technology as time goes on, or maybe now, but also threatening the bureaucracies they've built up in the protection of their jobs. How do you tackle that problem?
Well, as you described, the technology works. This is really, these projects are very complex, and this will be a significant undertaking. And all of these kinds of projects have some, what I call white knuckle moments in them. And I would anticipate that this will have a handful of those. What I do feel good about is that we have a governance model to address those, and that's one of the key reasons for success or failure.
Give us an example
of when they work well.
Give us an example of how you're going to be asking one of the 385,000 employees at the VA to do something different that they will embrace, even though they might perceive that it threatens their job.
Right. It's a continual sales process, as I describe it, which is we legitimately go out and meet with those individual groups, and you're actually continuing to sell to them. Here's the advantages. It's why it's really critical we do this crosswalk properly. We did have an opportunity as part of this contracting process to do something different than there was in the DoD process, because the DoD process was a response to a request. In this case, this was a direct to contract. It allowed us to work together for the past year to really learn and understand what each one of the, what really are the hot buttons
Now, the
here.
DoD is ahead of the VA in this whole scheme, and how are they doing?
I believe they're doing well. Like all complex projects.
Are they on time and on budget?
They're on, to date, that we're on that side. We think we'll stay on time and on budget as it relates to that in that perspective. Good. But I do feel like that the teams that we put together and how we'll go about the sales process and the collaboration will be effective here. Mm-hmm. It's critical we get the right people to the table. When they succeed, when these projects do well, you have the key clinicians that people look to. Mm-hmm. When they don't do well, it's done by a committee that's not part of those that are seen as maybe the informal versus the formal leaders.
We wish you tremendous success, Mr. Burke, and everybody else involved. Thank you. I yield back my 1 second of time.
Thank you, the gentleman, for yielding back. And just to show you how rapidly technology is changing, the fastest new supercomputer in the world is at ORNL that calculates 200,000 trillion calculations per second. That's 10 to the 18th power. So that's how fast this technology is changing. General Bergman, you recognized.
Well, given that bit of data, Mr. Chairman, I'm going to reflect to you a bit of change that occurred about 18 to 20 years ago when we were designing the Joint Strike Fighter. And I had a chance to sit in a meeting where one of the initial design criteria was to design an entire new aircraft around a 2,000-pound bomb. Think about how backwards that was. Someone very wise at the meeting said, how about changing the bomb? We're designing an airplane here, not a bomb carrier. And that's exactly what we're doing here in different ways. We're designing a system of systems that is going to be flexible enough to take advantage of changing technology. We've used the word change management here several times. Well, part of the change management is to manage the changes in technology so you stay ahead of the power curve as best you can. And as it relates to my district, one of the serious considerations we have in technology is rural broadband. Okay, we think about this system that we're going to design has to work for all of our veterans and all of our providers in those remote areas that as we transition the entire country to rural broadband, we have to realize that we don't want to leave anyone or any area behind. Now, Mr. Powner, how do you assess VA's readiness to standardize their clinical and administrative workflow? How ready are they to do that?
I think it's in its early stages right now, and I do think that's something that this tech subcommittee, I know it's a tech subcommittee, but it's almost like the technology, it probably isn't as hard as the standardizing the clinical workflows. And I think that tech subcommittee needs to have a hand-in-hand focus on that. Right now, it's in the early stages.
So compare that to the task of mapping VISTA.
I think mapping VISTA is further on down the pike. Again, that's close to being finished with the work that we looked up with on mapping VISTA.
Okay. Well, your written testimony mentions VA's present efforts to standardize VISTA. Medical centers have to request approval to alter their version of VISTA. Apparently, there have been roughly 10,000 of these waiver requests in recent years. What can you tell me about these requests? What does a typical request entail?
So we don't have specific details on those requests, Congressman, but I will tell you this. There's thousands of those requests, and that's too many when you start looking at the customization that needs to occur. And that's the whole reason why we're going the route that we're going here.
So would you consider
we need to control that. If there is any customization, it needs to be a waiver, and you really need to control it or deny it.
So in some ways, is this an attempt for the tail to wag the dog? We'd like to do it our way here locally, and we want to get a waiver because we don't like change?
Absolutely.
Okay, so we need, again, going back to build that culture that embraces the change necessary. Doctor, VA's testimony states that its planning will be in full swing over the next 3 months. Implementation begins October the 1st and is scheduled to finish in Spokane in March of 2020. Do you believe that is enough time to conduct those the thorough site assessments, finish VISTA mapping, and map all the workflows? We got enough time to do that?
Based on our discussions with several industry experts and bringing in those experts to these conversations, we feel that that's adequate time for workflow decisions and site reviews. We also have a partner that's done this at least 15,000 times. So, I'm hoping that Cerner, with all of their experience and expertise that they bring to the table, can add to this. I think what really helps here is that we're not trying to customize things, and we're trying to adopt, or we are adopting industry best practices, and we're adopting what Cerner has already built in to ensure that it fits our model. So I think that's adequate time for us. But of course, we will be working with the committee very closely and keeping you appraised of our progress. If we feel that we need adequate time to evaluate or work on something or delay the process, I think that's absolutely okay on my end from a clinical perspective, and I'll be the first to speak up. Okay. On the VISTA mapping, I defer to Mr. Short.
Okay. In 17 seconds or less.
On the VISTA mapping, we've done a couple different things. Right now, We've identified all the functional clinical modules we're confident that Cerner will replace. The non-clinical modules that do other functionality, we have 5 of them left we're still analyzing.
Okay, thank you. Mr. Chairman, I yield back.
Thank you, gentlemen, for yielding. Mr. Short, you were about to remind me of what one of my good friends who was a mayor of the county I lived in and retired now, George Jane, said. He said, Phil, son, when you go to Congress, remember, you can't quote silence. I was about to ask you if you want to speak after almost 3 hours at this hearing. So,
thank you, sir.
One question that, and we'll just do a 2-minute lightning round here, that came up with the DOD application, and I know, Mr. Wyndham, you know the answer to this, but became so enamored with the security, as obviously we can. Obviously, cybersecurity we're very concerned with about protecting patients. It slowed the process down so much that it became almost too cumbersome to use. I think that's been worked out, and I think that's one of the scalable things that VA can learn from what DOD did, and I'm glad you're where you are to sort of pass that information along. Am I correct or not?
Sure. I'm going to defer one more time to the Chief Technology Officer because he is my expert that we pay in that arena. And I think I have the answer, but I'll let him give you the answer if you don't mind, sir.
DOD's been very successful in getting that latency along with Cerner, getting that latency out of the system. VA is going to be incorporating the same security model that DOD put together that has a higher security posture than we normally have historically in VA, and make sure everything's encrypted, secured, perimeter-wise, and following that same model.
And as I understand, that was one of the things that slowed the DOD implementation down initially. That should not slow VA down.
That's correct. From lessons learned, we're taking the best of that. I'm in talks with the DOD on security every week.
Okay. Thank you. I'll yield now to Mr. Ticalo.
Hi, Mr. Burke. Does the contract you have with the VA also include responsibility for the community care interoperability?
It does. There are the standards for that community care interoperability, yes, sir.
And do you know on the DOD side, whether the Cerner contract with DOD, it covers the internal medical operations as well as TRICARE and that sort of thing? Because TRICARE is kind of, you know,
sure, outside. We can take that for the record. We don't really want to speak on behalf of DOD if we...
Okay, fine. Mr. Burke, we started getting into a conversation with Ms. Brownlee about the sticks that the VA might have in order to compel the other EHRs out there to kind of meet VA standards. And you were about to defer to the doctor to talk about that. Could you comment on the possible sticks?
I think that's you. Are you, Dr.?
Either you or the doctor.
I'll just make a comment quickly that, you know, I think the big thing on our end is user adoption. It's measuring to ensure that our users are actually using it and embracing the new technology to improve their work. And we have several ways to monitor that through things that we're purchasing in Cerner, several tools and dashboards, and we will continue to do that if we feel that it's inadequate training or we need better training.
What I'm getting at is that the community care providers, that obviously we have provider agreements that we have with them, and that we could, through those provider agreements, leverage the interoperability and the standards that they must adopt in order to meet VAs. I don't think it's fair that we compare VA care to community care without comparing apples to apples and having equivalent transparency, is what I'm getting at. Dr. Burke, you want to, or Mr. Burke?
The reimbursement piece from the VA and the community care is the important, what I refer to as stick, is basically the VA can compel those organizations to at least meet some of the data standards and the transaction elements, and that's what we're looking for on some of the on some of the business side from a provider perspective. So technically speaking, I feel confident that actually the industry is moving towards the right pieces around interoperability. It'll be about how we get the rest of the ecosystem of healthcare to participate. And so what I'm referring to specifically is some of the reimbursement elements of the VA as they engage with those community care providers.
Well, thank you. I yield back, Mr. Chairman. Sorry for going over.
Okay, I appreciate the gentleman's yielding, and I will now yield to you if you have any closing comments.
Mr. Chairman, let me just say that I agree with you. I feel a sense of trepidation about the amount of money that we're about to expend on this project. I also certainly hope, along with the GAO, that the ongoing costs after full implementation is going to be far less than the $1 billion we're spending to maintain Vista. And there are plenty of people out there watching from the IT world who regularly see government being hoodwinked by well, people seeking advantage, taking advantage of the government's lesser ability to kind of judge these systems. This is one of the reasons why I've asked the Congress to actually fund again the Office of Technology Assessment, so that we are in a better position to be able to interact with technology issues. But I also see, with the VA being the largest healthcare provider in the country, and our potential ability to interact with many private sector entities in healthcare, that we have a real chance to push issues like who owns medical data, and to truly put that data in a portable position for the patient, and to really shine a light on the proprietary practices of healthcare systems. The VA is publicly owned and is therefore, in many ways, far more publicly accountable. And I think we have an opportunity to extend that accountability into the private sector. You know, that's my hope and this opportunity, and that's why I want to make sure we get this right, because we have not only the ability to affect the health care of veterans, but potentially all Americans through what we're trying to do here. So I yield back.
Thank you, gentlemen, for yielding. Sorry, General Bergman, I missed you over there. You're recognized.
Well, as a Marine, I spend a lot of time in camouflage, so that's nothing wrong with that. Nothing wrong with that. I'd like to, Doctor, I'd like to just follow up with a little, just one more time to dig a little deeper into the planning activities and the implementation. Do you have any triggers in place that is going to give you a sensing if the schedules are all of a sudden not matching or things are out of whack?
Sir, within the next 60 days from Cerner Corporation, we have a multitude of deliverables, including an integrated master schedule, an implementation plan, a change management plan. We're reviewing those documents in earnest. So we're going to make sure we apply the appropriate rigor.
Let me ask you a question a different way. You got all the documents, you got everything. Is there anything in place to, when we call it a dashboard, all of a sudden it goes from green to red?
Yes, sir.
You know, and is there anything in place that is all your documents, the interplay between all the things you're doing, all of a sudden raise a flag?
Yes, sir. The risk management plan that we manage captures a multitude of risks that we think exist throughout the program. Red flags, yellow flags, green flags are all being monitored to assess whether we have a problem. We want to be preemptive and proactive. We've got a team of experts, both technical and clinical, to support that, and so we'll be ready to respond, sir. Our success revolves around program management oversight and picking the right partner. We think we have both, and so we're ready to execute.
In terms of, I got 23 seconds, in terms of an airline flight from takeoff to cruise to touchdown, where are you?
I would say on the runway, sir.
Okay.
On the runway. Yes, sir.
Very good. Now yield back.
That's a very good question. You know, at the end of the day, I'm going to simplify this. This is obviously a highly technical thing we're doing. At the end of the day, all the patient wants to know is, why did I come in and how am I doing? I mean, that's really why you came to, any of us that go to the doctor, that's what you want to know. Am I all right? Did you find out what I need to know? And does this new tool we have allow us providers to easily access that information, give that simple answer to the question to you? That's a simplified why somebody goes to the doctor. Why are you here today? At the end of the day, can we figure out what's wrong with you in simple terms, tell you what's wrong and how we're going to help you fix that? And we're going to continue. As I was sitting down thinking about how enormous this project was, I know the little rollout we did in our practice was not the easiest thing we ever did. And this is an enormous rollout, and it's going to take a team effort from everybody. And we're on the team with you. We're not here to fuss at you. We're here to try to make you successful, because ultimately it's about the quality of care we provide our veterans and our patients, and that's what it's all about. And so we're going to have many of these, and I thought standing up a separate, very small committee, probably will have 5 members on that committee, that's all, and that's their only focus, is to keep an eye on this and keep us on track and find out where we get off track and how we can get back on. I'm going to head back out to the Northwest at some time in the fairly near future and get a look and see how it's looking so that I can be up to speed in October when VA kicks this off. I really appreciate all of you being here today. I know you saw how many of our committee members engaged in this long hearing. No further questions. I ask unanimous consent that all members have 5 legislative days in which to revise and extend their remarks and include extraneous material without objection so ordered. Hearing is adjourned.